Well, thank you all for coming. I'm Mike Crooks. I'm a chest consultant based down in Hull, and I'm clinical lead for the Humber North Yorkshire Respiratory Network, which is why I've met quite a few of you on various Zoom calls, etc. And it's great to be up, presenting up here in York. This is the housekeeping, which is great. It comes with its own slide, which is absolutely fantastic. And it comes with great detailed instructions for what to do if an evacuation is called. Now, when I started looking at this, it took me about 5 minutes to realize where I was within York Racecourse. So we are here, I believe. Someone can correct me if I'm wrong, but this is where we are. So if there is an evacuation called, apparently we get some nice warning message that there's something happening, and then we get told to get out, and then we meet in here. So there you go, that's the housekeeping. The next part of housekeeping, I suppose, should be that if you have your mobile phone, it would probably be good to put it on silent. Otherwise, you've got the shame of pulling it out your pocket and everyone turning to look at you. Tonight's meeting is a bit different to most of the meetings we're used to, which is why we're all a bit more stressed and running around. Number one, we've got lots of cameras. And number two, we're live streaming this event because this event is supported by the Humber North Yorkshire Respiratory Network. And in collaboration with the Hull and East Yorkshire Respiratory Education Group. And as a result, we've got some of the talks live here, and then we've got some of the talks coming from Hull. So there's an exact mirror image of this, just with less windows, I think, down in Hull, where everyone has just had some food and is now sitting down. And I don't know whether they can hear me or not at this precise moment in time. No, they can't, so it's just yourselves, so that's good. So what that does mean is as we move between presentations and things, there will be a little bit of time to whisper to the people next to you while we switch the streaming between the two sites, and you'll get to hear some of us live and some of us streamed. So the question then is how long I have to keep talking to Phil before we start the streaming bit, and I'm hoping that Tom's going to indicate to me at some point because I haven't rehearsed any further stand-up for tonight. So are we okay to start the link? Excellent, just 1 minute. That is good. Maybe two. He's having a laugh, isn't he? So first things first, I think I'd just like to say thank you to those who had stands next door. I know some have maybe joined the back of the room. Some have disappeared off for dinner reservations because that's the way that they live, you see, these corporate lifestyles. Without the support from pharma companies and technology companies and other companies who come and support, diagnostic companies who come and support these meetings, it makes it a lot more difficult because as you can imagine, Tom's wage is huge, so it takes a lot to get him to give me thumbs up. So that's good. So we are now hopefully streaming to Hull. So we'll say thank you and hello to Hull. Thank you for joining us this evening. I probably know a lot of the people in Hull. I can't see you, so if you don't know me, I'm Mike Crooks, a chest consultant and clinical lead for the Humber North Yorkshire Respiratory Network. Hopefully Helena will have done some local housekeeping in Hull. The shared housekeeping is that because we're so technologically advanced, we have questions online. So if you're wanting to submit a question so that our counterparts in Hull can see it as well, if you have a smartphone, then you can submit it through your phone. It also means you can ask really difficult questions without me giving you the evils when you do. So if you have your phone, you can type in and go to slido.com. You may have had an email already today with the details, but if you didn't, it's slido.com. And once you are there, I'll give you a few seconds to get there, and I shall tell you the code which you type in. And that code is 2211752. So that's 2211752. And if you need that repeated, tough. That will get you through to our webpage where you can submit your questions. You can type it up. We'll be able to see it, and they'll be able to see it down in Hull as well, and hopefully the right person to answer it will be able to do that. So I think that is the housekeeping, and I've managed to eat 2 minutes into my own presentation, so I've only got myself to blame. So we'll move on, and I'm kicking off. You'll be sad to know. Talking about diagnosis of airways disease. And we're going to have the first kind of hour theming around about diagnosis and management of airways disease, and then we'll move on to some related topics. So this is what I'm going to cover over the next kind of 15 minutes. A bit of an introduction to airways diseases and why they present the way that they do. We're going to talk specifically about asthma as the most common airways disease. We're then going to talk a bit about COPD as the next most common airways disease. And then we'll talk a bit about what happens when we can't really tell, and we decide to create a new syndrome called asthma-COPD overlap syndrome, which is the not sure syndrome. And we can cover about how to try and define which we think is more prominent. So what are airways diseases? So obstructive airways disease refers to diseases which are associated with airflow obstruction or airflow limitation. So we're not that creative, and that's how it's defined. And generally, airways diseases are diagnosed with the help of spirometry, plus or minus other things. So if we just think about what airflow obstruction is, when we're doing forced expiration, as we do with spirometry, big deep breath in, blowing out as hard and as fast as we can, while we as a healthcare professional really annoyingly tell the patient to keep going, keep going, keep going, and they've got a purple face, and we're saying keep going, and then they want to collapse in a heap. But what we're looking at is how much air they can blow out in that first second compared to the total amount of air that they blow out. And what those of you who are familiar with spirometry will see is that this is a rubbish picture for me to have chosen, because this patient with airflow obstruction, they're still on the way up, aren't they? They've not reached a plateau, and really, for the forced vital capacity FVC, it should reach a plateau so that you know that that is the forced vital capacity. But if you are breathing through a narrowed tube, and therefore there is obstruction to the flow of air, you should still be able to get the same amount of air out, but it will take you longer to do it. Okay? So the amount of air that you blow out in the first second is reduced compared to the total amount of air that you blow out. And for ease, we often talk about 70% being the normal cutoff. So if you manage to blow out less than 70% in the first second, that's consistent with airflow limitation. If you manage more than that, then probably okay. Reality is that that differs a bit at extremes of age. So if we've got a 90-year-old and they manage to get 68% of their lung volume out in the first second, they're doing all right. We shouldn't worry about that too much. But generally a 0.7 cutoff or 70% cutoff is very reasonable. Next slide, please. And if we just think about why people get airflow obstruction, of course it's due to effects on the airways. And this came from a very old textbook, so I thought it must be right. So we've got A, where we get a bit of mucus production, and you get overproduction of mucus, and that takes up some of the airway lumen, and you can see that there's a narrowed space around it, so that can cause a bit of airflow limitation. We've got B there, where you get thickening, maybe some inflammation within the airway itself, which causes narrowing, and a narrower tube for you to breathe out. And then in C there, we've got a depiction of emphysema, where you get loss of support around the airways. Because if we all feel the main airway, which is the big important one, the trachea, of course, big airway, it's pretty rigid, isn't it? It's got cartilage around it, it's nice and well supported, that's not going to collapse, at least not easily. Whereas when you get down into the lungs, the smaller airways don't have any cartilage around them. They're floppy, they're not well supported, and it relies on the lung structure around them to hold them open. So if you get loss of that lung structure, as you get with emphysema, then you get less support around the airway. And if we go on to the next slide there, Vicky, you're doing a great job at now writing. There we go. When you're breathing in, as hopefully you are intermittently while I'm talking, your chest expands, it is pulling out. Your diaphragm at the bottom under your ribs is moving down, and that is increasing the volume of your chest. It's pulling your lungs open, and as it's doing so, it's pulling your airways open. So your airways, even if they're a bit narrowed, will open up, and you'll get air in okay, so not too much of a problem. When you're breathing out, your chest is squashing your lungs. It's pushing in. And that same thing happens to your airways. So if your airways are already a bit narrowed, of course they become more narrowed. And if they've lost the support around them, they get really narrowed, in fact, can collapse altogether, and air then gets trapped within the lungs. So people with airways disease predominantly have a problem breathing out rather than breathing in. Next slide, please. So what are the common obstructive airways diseases? Asthma is the most common. It's got a bigger circle there. It's not really scientific, the size of the circles. It's just slightly bigger. COPD, of course, is the next one. If we go into the next animations, amazing. You can see that asthma and COPD, of course, overlap. So we have some people who have elements of asthma and people who have elements of COPD, and they sit kind of in the middle, and they're a bit tricky. We'll progress even further here, Vicky. There we go. And we've got some bronchiectasis, of course. That's another airways disease, less common, but does affect the airways and can cause airway obstruction. And in fact, of course, there are others as well, which are less common. But the key ones that we're going to be talking about are asthma and COPD. And airways diseases can affect people at all stages of life. So, of course, we get airways diseases that affect babies. We recognize RSV and the talk about bronchiolitis and the panics that caused when we got that. Well, that causes airways disease in kids when they've got it, the viral infection. And, of course, then kids can go on to develop asthma, and they can develop other airways diseases as well. And, of course, later in life, if you've been exposed to relevant things, then people can develop COPD. And so airways disease can present at any time. And, of course, people can develop asthma later in life as well. And next progression there, Vicky. And of course, they cause lots of different symptoms. So breathlessness being common, wheeze, that turbulent flow of air causing that sound, which is the wheeze. Tendency to chest infections or attacks of increased symptoms, cough, sputum, often resulting in effects on work and school, and of course affecting what people want to do. I say exercise limitation, but really I should put activity limitation, because as people wouldn't necessarily say walking upstairs to go to bed or getting dressed in the morning is exercise, but airways diseases, particularly COPD, of course, can have significant impacts even on those activities. So lots of symptoms shared between the different airways diseases and affecting people at all stages in lives. So let's just think about those symptoms and how commonly they occur. So this is a large observational study. So I think this had several 100,000 people across Europe with COPD, and it was asked what symptoms affect you at least every week. And the different colours there reflect different severities as to how much they affect each individual. But you can see that breathlessness is very, very common. So 3/4 of people with COPD will experience breathlessness most days of the week. Cough and phlegm being quite common. Wheeze maybe a bit less so, less than half reporting wheeze with COPD. Chest tightness is a slightly more, well, it's a slightly more subjective symptom, isn't it? And a bit less clear as to what people describe there. So that's COPD. What about asthma? So asthma, very similar cluster of symptoms. So again, this is a meta-analysis. So this took a lot of different studies, lumped them together, and looked at what kind of symptoms were reported by people with asthma. A little bit trickier presentation, but the further you are towards the right for each symptom, the higher proportion of patients that reported it. But again, we can see it's wheezing, it's breathlessness, chest tightness, cough. Some of the more kind of allergic-y type symptoms, so sneezing and runny noses and nasal congestion being a bit more common in asthma. Exercise-induced bronchoconstriction, that's not a symptom as far as I'm concerned. Sleep disturbance. So these are the features that people describe with asthma. So I think we can probably see there's quite a big overlap between asthma and COPD in terms of presentations, which is why it can sometimes be tricky. But there are clearly differences which can help us to differentiate. Next slide. So, this is what asthma is. This is GINA's definition, so global guideline group, and it describes it as a heterogeneous disease, which means it's varied, so different people present a bit differently. But the key characteristics are that it's characterized by airway inflammation. So airway inflammation being the absolute key thing to remember about asthma and asthma management. People get those symptoms which we've described, and I've tried to highlight in bold. I don't know how clearly it comes across, but one of the key features that should really make you think about asthma and people presenting with these symptoms are that these symptoms tend to vary, and that may be vary throughout the day, so diurnal variation, but they also vary in time and intensity, and those variable symptoms are accompanied often by variable airflow limitations. So demonstrating that variation can be really helpful in identifying asthma. Next slide, please. And with asthma, you're often getting this transition from the airways from being fairly normal, when someone's not exposed to the trigger, whatever that is, or if they're effectively on treatment, and that person, assuming they achieve asthma control, should be completely symptom-free, to an inflamed airway with some symptoms, and then, of course, during an asthma attack, where you've got that really inflamed airway with the smooth muscle around the airway being more reactive and responsive, going into spasm, tightening, and causing those really prominent symptoms. And with asthma, you're often seeing the airways moving between these different stages over time, which is what then drives the variability. So how do we diagnose asthma? Well, there's different ways to diagnose asthma. We've got the BTS sign guidelines, which I'm going to show you in a second. We've got the NICE guidelines, which I'm not going to show you, which maybe tells you how nice I think they are, but it's just because we're limited in time. But in terms of diagnosing asthma, the good news is the BTS sign group and NICE guideline committees are all getting together, and they're going to play nicely, and we're going to have, hopefully, a combined guideline, which will tell us what to do in one document without slight conflicting approaches. So hoping for that next year. So what do the BTS sign guidelines say then? So we've got at the top there the characteristic features of asthma, which can be really helpful to identify, and they're the things that we've already described, really. So recurrent episodes, variable symptoms, absence of an alternative, that's always helpful. Recorded observation of a wheeze, so it's really good if you see a potential asthma patient and you listen to their chest and they've got a wheeze, make sure you document that, because that's really useful to know when you look back, if you're ever wondering about the diagnosis in the future, that they did have evidence of a wheeze when they were unwell. If they've got a history of allergies or other atopic diseases, hay fever, eczema, etc. And of course, if they've got evidence of airflow limitation in the past as a key feature of airways diseases. If you think it's a high probability that they've got asthma, then it's fairly straightforward. You initiate treatment. If they respond well to treatment, and that's an inhaled steroid, then you'd be pretty confident. You want to assess that response both in terms of symptoms and potentially improvement in their airflow limitation. And if you're satisfied on the basis of that, you diagnose asthma. If you think it's probably got asthma on the balance of things, then you can do some extra tests, so spirometry, you can do reversibility, you can do peak flow monitoring, and you can look for evidence of airway inflammation, so FeNO, which hopefully you'll have access to now, or blood eosinophils, and skin prick tests for atopy. So all these things building the evidence which allows you to feel comfortable with the diagnosis of asthma. And what we wanted to do as a region, because we recognized that where spirometry is a core feature of both BTS sign and NICE guidelines, and that we recognize that access to spirometry is still limited following COVID and recovery, was take the BTS sign guidelines and make them a bit pragmatic in response to the good access to FeNO now across our patch, but still limited access to spirometry. So I won't spend any time going through this, but essentially, if you're an adult or your child over the age of 5, if you think it's a high probability of asthma, it's good to do some peak flow and some peak flow monitoring to look for that variability. It's good to do a FeNO if you've got access to it. And if you're happy on the basis of the symptoms and those tests that it's asthma, then you treat them. And it's also good just to monitor response to that treatment. And that will be enough to satisfy a diagnosis. If you're not so sure, that's where spirometry probably has a good role in this situation. Let's move on then. So we're going to go on and we're going to jump to the next slide even there, Vicky, because we're going to talk about COPD very quickly, because COPD is the other common respiratory disease, but where it's less common than asthma, it results in a lot more hospitalizations and is associated with a lot of morbidity and, of course, mortality. So it's common, it's preventable, stop smoking early, which we'll hear a bit more about later, and it's treatable. So we have to remember that we can do a lot for these patients. And again, in bold there, I've put that it's characterized by persistent respiratory symptoms. So when we're thinking about how we differentiate asthma from COPD, where asthma, we're thinking about that variability, and that being something that should make you think about it. With COPD, in the definition, we've got persistent respiratory symptoms and airflow limitation. So that tends to be persistent and progressive. The symptoms are very similar: breathlessness, cough, sputum, and to develop COPD, you have to be predisposed to lung damage as a result of smoking, but you also have to be exposed to something noxious like smoking or biomass fuel burning, etc. Okay, next slide. So how do we make a diagnosis of COPD? So first of all, of course, we've got to have suspicion, so those symptoms we've presented. You've also got to have had a relevant exposure, which is important in terms of smoking or otherwise. And then I think it's useful to do some tests. And of course, spirometry, very important to show the airflow limitation we talked about. I think anybody you're considering a diagnosis of COPD should also have a chest x-ray, because by default they're in the at-risk group to have developed lung cancer, and you don't want to miss that, so we do a chest x-ray. And I think it's good also to do some blood tests, partly because there's more than just lung disease that causes breathlessness, but secondly, it does allow you to get a bit of a feel for what type of inflammation maybe that patient might be prone to, so the blood eosinophils, which can be useful then in guiding in the future whether they'd like to respond to inhaled steroids. Next slide, please. So this is just the final, at least Vicky's hoping this is the final slide, because I'm already, 2 minutes. I ran 2 minutes over at the start, so we're okay. This is to demonstrate, I suppose, some of the features which can help you to differentiate between asthma and COPD. And I'll come on at the end of, once we've heard about asthma and COPD management, I'll tell you why it is quite important that we get this right for individuals, and so that we prioritize the treatment effectively. So I'm not going to talk through that in any detail. I'll let you have a little quick read, and then we shall progress to the next slide, and we will not take any questions at present. We will take them at the end of the first session of talks, and I will be handing over to Hull. So this is where we really test the system. We'll hand over to Hull, where you will be able to see the next presentation, and Helena Cummings, who's the chair in Hull, will introduce our next speaker.
I'm very excited to welcome Dr. Kamdar. Is this your first ever in Hull? So fantastic to have you here, Uzma, who is going to give us an overview on asthma.
Can I talk? Yes, okay. I'm Uzma Kamdar. I'm one of the respiratory consultants in Hull University Teaching Hospitals, and I'm talking about asthma management today. I take special interest in airways diseases. So, asthma is a common condition, and it produces significant workload for primary care, as well as hospital clinic outpatients and inpatient services. About 5.4 million UK population is known to have asthma, and they are on treatment, and still about 160 new diagnoses are made every year. And that is why it is very important that it is diagnosed and treated optimally. So the main objectives of my presentation today is to understand basic steps of asthma management, a brief overview of advanced management options, and also to just have a brief understanding of when to refer. So the long-term goals of asthma management is to achieve good symptom control, as we are all aware, and also minimize the future risk of asthma-related exacerbations, mortality, minimize the side effects of treatment, and as well as reduce the risk of persistent airflow obstruction or fixed airway obstruction or limitation. That nicely takes us to this table from BTS sign guidelines, which eloquently expresses the long-term asthma management goals. And this is essentially the components of an asthma review, which should happen ideally annually, if not more frequently than that. And you can give the table a read in a minute. It addresses current symptoms in the form of bronchodilator use, validated asthma scores, also about future risks of asthma attacks, and to review current management. And at this stage, we should not be afraid, or we should not be hesitant to revisit our diagnosis if we need to. And if you look at this, it's a diagram from Gina, which shows very nicely that asthma treatment is not a one-off management plan. It's a constant review. So you see the patient, you assess them, you treat them, and then the patient must be reviewed to see their response. At which stage you either escalate their treatment or de-escalate their treatment based on their response. So that's where we are. Now, looking at the next slide, asthma is an inflammatory condition, which means that there is eosinophil recruitment, there is airway inflammation, there's mucus hypersecretion, and the treatment for this is anti-inflammatory treatment. The days of SABA monotherapy are long gone, and hence I'll talk to you in a minute. But if you have diagnosed asthma, you need to treat it and get those inhaled corticosteroids on board. Now, there are two stepwise ladders that you can see. The smaller ladder is the 2016 guidance and the BTS sign guidance, and the bigger picture is the 2019, which is the latest, which is probably in dire need of an update anyway. So the reason why I'm showing them side by side is to just emphasize the fact that asthma treatment starts with inhaled corticosteroids. Up until 2014, the guidance did suggest SABA monotherapy, but that's a complete no-no at the moment. And if we look at the higher spectrum of, and also one more thing that I would like to mention, which I can touch on in detail in a minute, is the best way to give inhaled corticosteroids, with GINA guidance states, GINA statement states very clearly, is maintenance and reliever therapy, or MART regime. Now, if you look at the higher spectrum, in 2016, it has mentioned oral corticosteroids, but that is a complete no-no at the moment. And if you are getting to that stage, there are specialist therapies that we can help in these patients. Hence, we discourage the use of oral corticosteroids in asthma management now. And in between, additional add-on therapies, your leukotriene receptor antagonists, macrolides, long-acting muscarinic agents, and on top, and also theophylline, which we'll talk about in a minute. So that's that. Now, this shows, so I'll quickly whiz through that, but this is the GINA update. Now that's from this year, and it has two tracks. The track on the top, the basic difference between these two tracks is that the track on the top is about LABA ICS as reliever therapy, and the track at the bottom is about takes SABA as a reliever therapy, but the rest of the basic concept is the same. Now, GINA has this has quite good evidence behind it. We have Sigma 1 and 2 trials, which have clearly told us that PRN or as required LABA ICS treatment. So I'll quickly whiz through that, but okay, as required. So this year. Yes, I could talk. So so I was talking about Sigma 1 and 2, that it clearly states that the LABA ICS treatment as required is superior to SABA monotherapy. Okay, I will not look. So it's superior to SABA monotherapy, both in reducing exacerbations and in symptom control. And it reduces the risk of exacerbation by about 2/3. And in step 3, a preferred treatment is ICS formoterol MART regimen, with similar or better effect in reducing exacerbations. Now, the problem, the only limitation with MART therapy is that you can only have it with formoterol at the moment, which is a rapid-acting LABA. And you can see that there's a table, and it just shows the current ICS formoterol combinations that we can use and that are licensed in the UK. There are actually, these are 5 inhalers, but there's another strength of Symbicort that's missing out of here. But that's that. So quickly going through next slide. I mean, that's just to emphasize, if there is one take-home point from the presentation, that is that SABA monotherapy is no longer indicated. Liver overuse, I mean, it's a global problem. Use SABA, the receptors downregulate. You need more inhaler, and as a result of that, there is a greater overuse. And we all know that more than or equal to 3 SABAs per year in ED attendances and hospitalization, regardless of the severity of disease. 12 SABA inhalers per year increases the risk of death, and nebulizer does even more. So, just a few quick points about safety of inhaled steroids. I mean, it's more related to the inhaler technique, so oral thrush that we are all very well aware of, and we know what advice to give them. And possibility of long-term effects on bone. I mean, systemic review reported no effects on bone density up to 1,000 micrograms of budesonide dipropionate. Significance of small biochemical changes in the adrenocortical function, unclear. I am not sure about that. Okay, now the additional add-on therapy that was in the, if we go back, I won't ask you to go back. If we go to, yeah, just a few more slides, that BTS ladder. Yeah, that one. So That one, yeah. So the additional add-on therapy, the leukotriene receptor antagonists, I mean, there is no direct evidence for add-on therapy to LABA ICS, but it's extrapolated from add-on therapy to maintenance low-dose ICS, which is probably applicable. And yes, there is improvement in symptoms and in reducing exacerbations. Same is the case with leukotriene, with LAMA agents. I mean, theophylline, it has a very, we still use it, but it has a very wide adverse effect profile, so it's just cautious use. And one thing that I've not mentioned here is macrolide use. So azithromycin, which again, the BTS guidelines for macrolide suggest that that we can add it on as treatment if you've required more than one, if you're on the highest ladder, so you're on step 4 and 5, or you've required more than one course of one course of oral corticosteroids in 12 months. Okay, now going back to so one slide forward, yes. I will quickly touch that. I know I'm short of time. Helena is smiling, but just severe asthma quickly. So severe asthma, I wouldn't go into the details of difficult asthma, but severe asthma in brief, it's uncontrolled symptoms despite adherence, despite optimization of treatment, and despite addressing the contributory factors, which again are beautifully expressed in this table. So if you've checked the inhaler technique, if you have looked at alternative diagnosis, if they have good adherence, if you've changed whatever you could, overuse of SABA is addressed, psychosocial factors are addressed, medication side effects are kept to a minimum, and despite then, if your disease is not controlled, then that is classed as severe asthma, which again forms about 3.4 to 4% of the current asthma population. So this is a study from Netherlands. And it tells us, so it has, so the 3.7% of the severe asthma population is based on those who were on the higher side of treatment and who had good adherence to their current treatment, and also on those who were on oral corticosteroids. So that's that. Going to the next slide. This is interesting. And how long have I got? A few minutes? No? Okay. Okay, so I really want to talk about this at least. So this is a survey on primary and secondary care population and primary and secondary care healthcare professionals, and it is this was done, if I remember it right, about 4 to 5 years after the NRAD report came out. So there's this variable threshold in all healthcare professionals about referral to secondary care. Before I talk about the results of that, it is interesting to know that the NRAD report 2014, so the review of asthma deaths, it clearly suggested that those who require more than 2 courses of systemic steroids in 12 months, or who are on the higher side of ladder, you should refer them to secondary care for a further review. So looking at that, keeping that in mind, and still despite that report, several years down the line, only 9 or 10 or 11% of healthcare professionals thought that 2 oral corticosteroids or one severe exacerbation is worth a referral to secondary care. So that is slightly shocking. Now, this is small print, and this is completely out of scope of this presentation, but this is what happens when patients are referred to secondary care. We review their diagnosis, we look at other conditions, or other asthma mimics, should I say, like COPD or bronchiectasis or inducible laryngeal obstruction or dynamic airway collapse or tracheomalacia. We look at their biomarkers like FeNO, their IgE counts, their allergens, their eosinophil count, and based on that, if they have type 2 airway inflammation, we can consider biological therapy or the specialist agents as highlighted there. I have two cases which I will leave for now, and I will stop here, and we'll take questions in the end. Thank you.
So I will now very happily hand you over to Caroline Everett, a consultant chest physician here in York, who's going to be telling us about management of COPD. So thank you, Caroline.
Thank you. Hello. So thanks for asking me to talk. When I was a baby doctor, I was told that you could never give a talk without telling people what you're going to tell them, telling them, and then summarising at the end. So this is my attempt at a summary slide at the beginning. Anybody who knows me knows that I struggle to talk for just 10 minutes about anything. So I'm kind of hoping that Mike will do me some semaphore when I'm out of time and then pull me off stage. Fine, so if you move the slide on, thank you. So I'm going to talk about management of COPD, and since Mike was rather disparaging about the NICE guidance for the asthma, basically what I'm going to talk to you is based on the NICE guidance for COPD. It hasn't changed a lot over the last few years. There's a statement on their website saying that they looked at it in January this year and decided they weren't going to change anything for a while, so carry on. But this document is 77 pages if you actually print it off. So most people want a bit of a easier to use summary, particularly if you're not a specialist and a COPD geek like me. Let's move on. So this is just the first page this is the local guidance that we've currently using in the Vale of York and North Yorkshire CCG. For those people in Hull and who work in other areas, I'm sure you have your own local guidance. And usually you get a document, something a bit like this. They all look a bit different. They like to use nice colours. Quite often they have pictures of inhalers and prices on to give everybody a bit of a kick up the backside about being careful with what you prescribe. The commissioners like us to sort of recommend what your first choice or second choice inhaler might be. I'm not going to talk too much about inhalers. I'm not going to talk too much about choosing one over the other. It's all about getting the right device, the right inhaler for your patient. But actually, before I talk too much about inhalers, if we move on to the next slide, I'm going to talk about all the other stuff, because I think we get very focused, particularly, I'm a doctor, and particularly as doctors, we've got access to the prescription pad, and that's the quickest way to get somebody out of the room, isn't it? You give them a prescription and send them to pharmacy, don't you? And we know in many long-term conditions, and COPD is no exception, that that's a really small part of the benefit that we're giving our patients. This slide is the pyramid on the left is about 10 years old now, and that's following some work that was done by the London Respiratory Network. And it talks about high-impact interventions, and things that are bigger at the bottom of the pyramid are things that are more cost-effective. It talks about cost for quality-adjusted life year, and we're looking at things like giving people the flu vaccine, getting them to stop smoking, getting them to pulmonary rehabilitation. A lot of these things not only have a big impact on the progress of the disease, but they can affect how your patient is now, and they affect the disease progress. Inhalers, it's a little bit out of date because you've got tiotropium and LABA inhalers, and we don't tend to give those on their own anymore. Sort of kind of towards the top, and then things that are very expensive for the output, triple therapy, and right at the top is telehealth, which is actually advised against in the NICE guidance for COPD. This not pyramid on the other side, this is data. It was actually for Wales, so we don't have to beat ourselves up about it in Yorkshire, but this is actually the percentages of COPD patients that were offered those different treatments, and that's data from the National Asthma and COPD Guidelines, I think from 2015 or something like that, so it's a few years old, but you can see there's quite a lot of people on triple therapy at the top, and very few people getting offered smoking cessation therapy, pulmonary rehabilitation somewhere in the middle. We move on. So any pathway, before you set off towards the misty mountains with your patient, the first thing you have to think about is make sure that you've got the right pathway for your patient. So have you got the diagnosis right? And Mike's given us a good summary of how we look at COPD diagnosis. Do you have a patient with the right sort of risk factors, clinical symptoms, and hopefully confirmed by spirometry? We also talk now a bit about the phenotype. So that's, again, Mike was talking about that you get overlap. Some people have asthmatic type features, even though they have a diagnosis of COPD. Some people are frequent exacerbators. Some people are just breathless. So think about what's going on for your patient. And also the severity obviously affects very much where you go. And then my comment at the bottom is a little bit flippant, I know, but if you're going to head off down this path with your patient, you need to do the basics. And if you haven't got your walking shoes on and a good pair of socks, you're going to run into trouble. So that's what I'm going to talk about next. And this is what NICE calls the fundamentals of COPD care. And I'm a big believer, I'm a bearer of a very simple brain, and I like to do the basic things right first, or if not, I'll tell everybody else to do the basic things right first, because it makes a big difference to the success of your treatments and the other fancy, clever things we want to try and do later on. So the first thing to do is you have to offer treatment to help your patients stop smoking. And I'm really pleased that we've got to talk about stopping smoking later on. This isn't a public health issue. It's not a matter of personal choice. It is a fundamental treatment for your sick smoking patient. So we need to really support them to get off the cigarettes. Everything else we do is less effective or possibly even ineffective if they're still smoking. And we know that stopping smoking improves so many parameters. The oxygenation gets better, their exacerbation rate goes down, their comorbidities and their other problems also are less problematic. Secondly, we need to make sure we offer them vaccinations. We've obviously got a new vaccine now that we offer people, the COVID vaccine as well, but pneumonia and flu vaccinations are important. If indicated, it says we need to offer them pulmonary rehabilitation, and that's definitely in a lot of parameters of quality of life, breathlessness management, mastery of their condition. There's lots of factors where pulmonary rehabilitation makes a lot bigger difference than all the fancy inhalers and other things we can do. So we know that we don't send enough people to rehab. And it's not difficult. The criteria are pretty easy. You have to have a patient with a diagnosis. It doesn't only have to be COPD. Our rehab services will see other people, but they need to know what the diagnosis is. The patient needs to be willing to go, and the patient needs to be breathless. There's usually a requirement for them to have breathlessness on exertion. And they also need to be not about to collapse when you start exercising them. So if they've got unstable angina or really, really tight aortic stenosis, perhaps get that sorted first. But otherwise, it's quite straightforward. You need to co-develop a personalised self-management plan. And self-management plans in COPD perhaps aren't as strongly evidenced as in asthma, whereas we know that we can prevent exacerbations with good self-management plans in asthma. It's less well linked in COPD, but we know that any chronic condition, your patient needs to understand what's wrong with them, and they need to know what to do when things aren't well. Because most patients say, I know I'm exacerbating, because they can recognise the symptoms. If you give them the tools, you need to tell them what to do next. And also optimising treatment for comorbidity. So a lot of these patients are smokers or ex-smokers. They have other health conditions. Other things make them breathless. Other things make them unwell. So we need to obviously think about the whole patient. Can we move on, please? Inhalers. Finally, she talks about inhalers. NICE tells us to start inhalers only if all the above interventions have been offered. And if inhalers are needed to relieve breathlessness and exercise limitation, and they've been trained to use the inhalers. That's really important, isn't it? I've got a picture here of my favourite patient, and this is really, as I say, labouring the point about the fact that you need to get the device and the technique right, and sometimes you need a carer or somebody to help if they're struggling. But my cat's not going to get any drug in at all unless we've chosen the right inhaler for that patient. And the guidance talks about giving some short-acting beta agonist or somatrovent, which we see less of nowadays. But again, you have to think about, do they need a spacer? Can they take a dry powder inhaler? All those sorts of things come into the assessment. I've got 2 minutes left. Carry on. Next slide, please. If the patient is still limited by symptoms or has exacerbations despite treatment, this is where we're thinking about the phenotype. We used to go on to give them Spiriva, didn't we? Give them a bit of tiotropium, but we don't do single bronchodilator therapy anymore. The guidance says you either go down LABA and LABA combination, because that's more effective for breathlessness than just one bronchodilator, or you can go down the LABA and steroid route. And the reason that you might choose one or the other is if you can predict or can guess that that person might be steroid responsive or not. We know that steroids, inhaled steroids, do carry a risk with them. There is a small but measurable risk of pneumonia. We know that some people that use a lot of inhaled steroid can get systemic absorption, and other, they come back to clinic, don't they, and they show you their thin skin and say, I bruise really easily, or they get osteoporosis. There's other reasons why they get those problems as well, but we shouldn't give them inhaled steroid unless we think they are likely to respond to it. And so they talk about asthmatic features, and that's basically defined as people who've had a previous confirmed diagnosis of asthma or atopy. So I guess those people who have been smoking asthmatics who've gone on to develop COPD as well might come into that group. People who have a lot of variability of airflow limitation, and they talk about 400 mils in spirometry difference or 20% change in FEV1, which is quite a lot of difference, actually, if you ask me. But or people who have a higher eosinophil count. We talk about, on the blood eosinophil count, basically anything in the top half of the normal range. So that's usually 0.3 or higher. That's what people, lung doctors like me, get excited about. It's a sad life, isn't it? And so that will decide you which route you're going to go down. Next slide. And then if you're really struggling and they've still got day-to-day symptoms, or they're exacerbating more than once a year despite therapy, then you might think of going on to triple inhaler therapy. Again, we need to make sure that the non-pharmacological treatment is optimised and that exacerbations are due to COPD and not something else. And if it's the breathlessness that you're treating, you're supposed to go up to triple inhaler therapy for 3 months and review, because if it doesn't make a difference, you should probably go back to your LABA-LAMA inhaler. If you're escalating treatment because of exacerbations, that's more difficult, because you kind of have to wait a year to see if they stop exacerbating. So a lot of people end up on that therapy. And then you may explore further treatments. Next slide, please. So other therapies, got to the point where I'm just listing things now. Oral mucolytics is probably the commonest thing that I see, and I think we're better at it, but quite often people come, they've got lots of symptoms, they say the inhalers aren't really sorting it out for me, doctor, and quite often if you talk to them, the patient will tell you if they feel they've got a lot of mucus on their chest, or they're getting really tired and having a lot of difficulty getting rid of it. So trying a mucolytic, carbamazepine, or sometimes we use Naxis now if they can't tolerate that, does well. Optimise their nutritional status. We know if people are getting really underweight or less commonly very overweight, that can have an impact on their breathlessness. Try and identify and manage other issues such as anxiety, depression, panic attacks and things. Oral theophylline I've put in there. I'm not sure that people would initiate that in primary care. It requires drug monitoring. There's lots of interactions. There's a lot of caveats. But it is a treatment that's available. Sometimes you need to give them diuretics. They're getting cor pulmonale and heart failure. But again, you might be calling for a bit of medical help to kind of diagnose that and exclude other causes. Safe self-management plans. And obviously with your more severe patients, we can go down a bit of a palliative sort of route as well. I think last slide. Okay, so this is about when to refer. So if you think your patient is breathless and and having symptoms, do consider referring them to rehabilitation. And you can usually refer them directly. You don't have to refer them to a hospital medical respiratory clinic. Do they need home oxygen? So if your patient is having low oxygen saturations, usually defined as 92% at rest on air in a stable state, so when they're not exacerbating, and you think you've optimised everything else you can, then you can refer them on. But they really, really need to be an ex-smoker, a sustained quitter to qualify for home oxygen therapy. If you've got diagnostic uncertainty, you might need to ask somebody like me to scratch their head about it. If you've got somebody with frequent admissions, or you think they've got complications, so they've got polycythemia, their haemoglobin's high, they've got cor pulmonale, they're getting swollen ankles, they've had episodes of type 2 respiratory failure, a lot of these people we will pick up because they end up coming through acute admissions, but the system's not perfect. We don't always, so do refer and let us know about those people. If you think they're going downhill really rapidly, or if they've got sort of very uncontrolled symptoms despite optimum treatment. There are other reasons to refer, but those were the main ones I could think of. Next slide, thanks. And then this was just about, again, a little bit about what we might do if you send them to us, apart from some of the things that we've already talked about. Sometimes you'll see patients more frequently now on low-dose prophylactic macrolide antibiotics. Again, then there's a lot of checks and things to consider before you start, so that's usually specialist initiation. Hot HMV is people that have type 2 respiratory failure, so they might be on home oxygen and a ventilator as well, a non-invasive ventilator at home. Lung volume reduction is one of the big sort of newer emerging treatments for the people with a lot of emphysema and breathlessness. We might assess them for some surgical intervention. Roflumilast I've put in small because I rarely use it, but it's occasionally helpful for people with chronic bronchitis and severe disease. And lung transplant should probably also be in small because realistically not many of our patients get that far, but particularly if you have a younger patient who's not got too many comorbidities, that might be something that we consider. That's it, thank you. So my summary is mainly check you're on the right path. Make sure you've got your shoes and socks on and you've done all the basics. And when things aren't going well, go back to the beginning and think about, is there something else going on? Not all breathlessness is COPD. Check your inhaler's device and technique and adherence. And then we'll consider other things, other therapies, and ask a friend if you need help. That's it, thanks.
Thank you very much. Yeah, that was definitely louder than the whole clap, I think, most certainly. Thanks very much, Caroline. So we're going to take probably some brief questions now at the end of this next talk. So we're going to move straight on. So I'm now going to have a quick chat with you about why it's important to get it right. So we've talked a bit about diagnosis, we've talked about asthma management and COPD management, but why is it actually quite important? So we'll move straight on to the next slide there, Vicky. And we've covered the fact that people with asthma and COPD, there's often an overlap. And there's definitely people in the middle there, but there are clear people with asthma and there are clear people with COPD, but where it gets a little bit trickier is in that middle. So we'll move on. The reason that it's important, we've seen the BTS sign asthma guidelines, stepwise management. This is from GOLD in terms of selection of your initial pharmacotherapy. So treatment, inhaler treatment, particularly for COPD. And if you hit the button there, Vicky, we'll see the bits that I've highlighted, which really in asthma is that inhaled corticosteroids are the cornerstone of management. And that comes back to what we said about asthma being a disease characterized by airway inflammation. So it's really important that we control that inflammation. And where Uzma was talking to you about how SABA and over-reliance on SABA inhalers is potentially harmful, and we know that the more SABA people are using, the higher the risk of asthma attacks, the higher risk of asthma mortality. The less inhaled steroid an asthma patient is using, the higher risk of mortality. Okay, so we need our asthma patients to be using steroids. Whereas in COPD, we can see that depending on which group you're in based on your symptoms and exacerbations, actually the cornerstone of COPD management is good quality bronchodilation. And Caroline mentioned about how we don't use single-agent bronchodilators, particularly in this country, because dual bronchodilators are more effective. But they really are the cornerstone, and then it's in the more severe, frequently exacerbating eosinophilic-type patients where the inhaled steroids come in. So in asthma, inhaled steroids are the cornerstone of treatment. In COPD, bronchodilation is the key to management, but of course, in both sides, we also use a combination of all of these treatments, don't we? So next slide, please. So if we say that actually all those inhalers that we use in asthma, we also use in COPD and vice versa, or at least most of them, then why does it matter? So this is a chap who came to my clinic. So this is a genuine case of a gentleman. He was 66 years old, and this was back in 2018 this happened, so you can see how it stuck in my mind. And he was referred to see me in my severe COPD clinic. So he'd been diagnosed with COPD for about 4 years. Symptoms tend to be a bit worse in the morning and at night. There was no obvious triggers. And the main issue was that he'd been referred up because he'd had recurrent exacerbations. So 16 courses of antibiotics and steroids in the past year. So if we know that one course of high-dose inhaled steroids, so 30, 40 milligrams, for example, is associated with increased risk of cataracts, diabetes, these things, 16 courses is really associated with that. So that's toxic, really, for this chap, and is going to cause lots of problems. He feels really well when he's on treatment, but deteriorates within a few days to weeks of completing. So, Vicky, let's go on to the next one. Thank you. So this is really the pattern that was happening. Red line, the symptoms. You can see how much time I spent drawing this. Symptoms get worse, then they get better. When he goes on oral steroids and he comes off the steroids, the symptoms get worse. And this is the pattern that he was following in 16 times in the year. So next one then, Vicky. So these were his treatments. So he was on tiotropium, so he was on a LAMA. He's on ICS LABA combination inhaler at a high dose of inhaled corticosteroids. He had some omeprazole in there for good measure. He was an ex-smoker, which is a 20-pack-year smoking history. He was a typical retired farmer, so didn't complain about anything. Very stoic chap, lived with his wife. On good days, he lived on he had a farm, didn't he? Retired farmer, still lived in his farm. He had a lake down in his grounds. He used to, on a good day, walk down there and he'd make sure all the grass was cut and make sure it was all well maintained. But on bad days, he really struggled to get dressed. So really quite marked variation in terms of the symptoms and how he was affected. Next slide, please. So, of course, he came up to, we do tests, don't we? We do tests in secondary care. So this is his lung function here. So we've got his FEV1, the amount he blew out in the first second, was 1.63 litres, which was 49% predicted. That's post-bronchodilator. This is pre-bronchodilator, was 1.31. So it's gone up a bit, 320 mils of reversibility, which is 25%. So he has airflow limitation, and he has a degree of reversibility. His blood eosinophil count, 0.64. So above 0.3 suggests in steroid-responsive disease. Pheno 33, which is in the kind of intermediate range, didn't have any A to B. And I did wonder, because he'd had so many courses of steroids and he felt unwell every time he came off, whether he maybe had a bit of adrenal insufficiency. So because of the steroids, his adrenal glands might have become lazy, stopped producing steroid himself, and he was actually then steroid deficient. But his synecthin test was okay. This is a CT scan, and you might not be as familiar with CT scans, but on the left side of the screen for you, which is actually his right lung, you can see there's a little white patch in there. So he has a bit of emphysema, which I'm not going to go into any detail about, but he has a little white abnormality, which suggests something a bit more solid in his lung, which is not so good. Next slide, please. So he'd come along and he had all these symptoms, and he was on quite a lot of treatment for his Airways disease, but actually I was more worried about this white thing in his lung at this point in time. So we did a PET scan. So a PET scan, you get a radioactive tracer injected into you. It's taken up by metabolically active parts of the body. And this little white patch on the CT scan was taking up lots of tracer, suggesting that it was metabolically active. And that's consistent with cancer. So that was our suspicion, was that this was a probable lung cancer in this situation. When he came to see me for the results of this, he was doing well. He could walk about 1 or 2 miles. He'd had a couple more courses of steroids and antibiotics, and we took his case to the lung cancer MDT. He'd thought it was felt to be consistent with malignancy. Bronchoscopy didn't give us any cells, and it was thought he should be referred for surgical resection of that tumour. Next slide, please. So he turned up to see the thoracic surgeon after I told him how good he was, and he was walking 1 to 2 miles, and he could hardly get into the clinic. He was so out of breath. And the surgeon took a look at him, thought, oh, he's really breathless. No, he's got COPD, chronic progressive condition associated with progressive symptoms without a great degree of variability. But he was unfit for surgery, went back and discussed his case in lung cancer MDT, felt that he was too severe and too limited by his chronic progressive airways disease that he should be for best supportive care, not for active surgical management of his cancer, not even for oncological treatment, because he was so unwell when he attended clinic. That's because he's got a diagnosis of a condition which is chronic and progressive. Yeah? The next slide, please. So I heard about this. I wasn't overly happy. I thought, this isn't quite right. And where we've said we do not treat asthma with maintenance steroids, which I agree with, we should avoid that, and we should use better treatments. But in his case, it was absolutely essential that we stabilized his lung disease, okay, because he needed to get an operation and get that cancer taken out. So we started him on some oral prednisolone, and this was his spirometry from before, FEV1 of 1.31 litres, and then he'd had a bit of oral pred, just 10 milligrams, and had gone up by about a litre in terms of his FEV1. Next slide, please. He was feeling an awful lot better, but he'd been so put off by the fact that he was told he was going to die if he had an operation to remove his cancer, he decided then to have stereotactic ablative radiotherapy for his lung cancer instead. So he went on, he had that treatment. We were trying to wean his steroids and failed miserably because his symptoms deteriorated each time. Next slide, please. And so what we did is we took his case to our regional MDT, and he was then started on one of our fancy biological therapies. So he started on mepolizumab, which is a drug, it's an injectable drug, a subcutaneous injection. It's only once every around 4 weeks. And for him, and the type of inflammation he had, it completely controlled his asthma inflammation. We got him off his oral steroids, and he maintained quite a good quality of life. What I can tell you is that about 3 years later, his COPD started to catch up with him. So he started to develop more consistent exercise limitation and breathlessness. And then we started to go through all the things that Caroline has just told you about. But at that time, it was very much asthma predominant airways disease. And that COPD label led to assumptions which potentially could have impacted his treatment very significantly. So it is important that we do try and get it right. Okay, so next slide, please. There we go, concluding remarks. And I think we will probably have time for about -5 questions. Next slide, please. But we should have at least 1 or 2. Oh, excellent. We've got a photo. We're going to stay here. And the questions are mainly for you, Caroline. You'll be very pleased to know. So the first up question we've got here is, would you do an alpha-1 antitrypsin test routinely when looking at initial diagnosis of COPD? We're going to give that to you because it was COPD management was yours. So there we go. I'm going to give you...
I have to say that I don't do that in everybody. I will ask for alpha-1 antitrypsin test if I think somebody's perhaps not got an obvious risk factor. So if they've not been a smoker, if they're a bit younger, if there's sort of other concerns. But I don't use that to diagnose COPD in all patients. Sometimes we check it in more severe patients because it may affect their progression and consideration of other advanced therapies, and obviously it may have implications for family members, but I don't check it routinely.
Excellent. I'm very glad that I'm also on the same boat. We're in agreement there. I'm getting it right so far. Next question was around about macrolide antibiotics in COPD. So this is a statement, I suppose, saying that they were advised by a colleague, I presume, in general practice, that the macrolides should purely be in the remit of secondary care and not initiated in primary care. What are your thoughts on that, Karen?
I would tend to agree, just because there's quite a lot to consider with macrolide prophylaxis. It can be very effective and can transform progression for some patients, particularly those that are exacerbating a lot. But you need to be clear that you've got a secure diagnosis. We're not missing other conditions like bronchiectasis and things which are treated a little differently. You need to consider that we're not going to actually make the patient resistant to a very useful antibiotic if they have particularly atypical colonising bugs in their chest, such as non-tuberculous mycobacteria. You need to check for interactions and risk of long QT syndrome and things like that. So I would suggest that it should be initiated in secondary care. Quite often we will then pass it back to primary care to continue if we think that's successful treatment that should go on, and would give you advice and support as needed.
Thanks very much, Caroline. And clearly, macrolides are very effective treatments, aren't they? And I completely agree with all those considerations and things that you have. In Hull, We don't necessarily want to see all the patients that you think might require macrolides, but what the mechanism that we do have is that we have a COPD MDT each week. So all community services who are involved in managing COPD attend that. There's consultant review there. We have access to bloods and imaging and all those kind of things. So often we will recommend azithromycin through that setting, I suppose, so it can be initiated in that context. But any questions, of course, that it can come through that MDT. And the final question, because we will then move on to the next talk, is at what stage would you suggest patients have rescue packs for COPD?
I guess I'm not such an expert in rescue packs because I don't work in the community, but I would suggest that patients who are exacerbating frequently, and it's all to do with how you organise your delivery of care, isn't it? So we all hear the stories about people that have trouble getting into the GP surgery, and so actually if they have if they know what they're doing, if they can recognise their exacerbation and have an agreed management plan, then I think, and then they have a significant risk of exacerbating, I think they should have a rescue pack. But I think it's obviously important that there is some oversight of that, so they have a way to let their practice know that they're using their rescue pack, not least so that they can get a replacement, but also so that their use of that can be monitored and just to check that it remains appropriate, because we all know that some people can reach for the steroids a bit quickly because they're very anxious about their symptoms.
Absolutely. Well, thank you very much, Caroline. That's been really beneficial, and obviously all the questions related to COPD, so that was good. Nobody cares about asthma, clearly, which is good. So we are now going to transfer back to Hull. It's going to be seamless and smooth. It's all going to go beautifully.
So it's my pleasure to welcome John Hancock now, who is the Humber and North Yorkshire Service Delivery Lead. And he's here to talk to us today about pulmonary rehabilitation and updates. Thanks, John.
It's been a nerve-wracking evening. Normally, at these presentations would be the most nerve-wracking, but being behind that laptop and that sound system and connecting with York, I feel as though I've been on NASA Control Centre landing space shuttles. Okay, if we go on to the first slide, please. So, why am I here? So, about 18 months ago, I was quite happily talking about cancer, I was talking about stroke, and a little bit of palliative and end-of-life care services. And then about 18 months ago, somebody asked me if I would become the strategic lead for respiratory services for Humber, Coast and Vale. What started out as 2 days a week has kind of expanded and has probably become 4 days a week plus. But I'm here in a sense that for pulmonary rehabilitation, I'm a bit of a convert. And I'm a convert for the same reason that whilst I was waiting, less stressed, for all this to happen, I was talking to a gentleman in the waiting room back there. He'd suffered from long COVID. It had nothing to do with his conference. And we were talking about his experience and the fact that he had been regenerated by the fact that he decided to take up walking. And that walking exercise had helped him on so that his exacerbations had moved on from 1 month to 2 months to 3 months. And he was quite happy for me to talk to you about his experience to introduce this subject. You probably know a lot more about pulmonary rehabilitation than I do, but very briefly. So it is an exercise programme designed for people with lung disease, and we've heard quite a lot about that in the talk already. It's tailored, helps people to understand their conditions better, and helps them stop feeling including short of breath. The design of it, typically 6 to 8 months, 2 weeks, around 2 hours a week, but also, as well as individual therapies, group therapies. In terms of the individual therapies and group therapies, COVID gave us quite an opportunity to test out some of the opportunities to provide pulmonary rehabilitation at home. That wasn't just around exercises that could be delivered over the internet, but there was one area, particularly in North Lincolnshire, that had actually trialled virtual reality in pulmonary rehabilitation. First opportunity I've ever had to put on a pair of VR spectacles, but now there's another project hopefully starting in York soon. If we could go on to the next slide, please. So who can benefit? Well, mostly people who have PR, have chronic obstructive pulmonary disease, but other long-term conditions such as bronchiectasis and pulmonary fibrosis. Now, the challenge for me as a manager who's not clinically trained in front of all you clinicians is, apart from fear, is the fact that I had to look up how to pronounce that long word beginning with B. So if we could go on to the next slide, please. So patient outcomes for pulmonary rehabilitation. So the evidence shows that accessing pulmonary rehabilitation improves people's ability to walk further, makes them feel less tired and breathless when carrying out day-to-day activities. But one of the things that pulmonary rehabilitation has got an evidence base for is that if you can support self-management and reduction in exacerbations, we also have reductions in acute and emergency admissions and reductions in primary care appointments. But clearly the most important thing is the improved quality of life for patients. I don't see it, I'm not a clinician, but there are people here and in York who can see that improvement in patients who are sitting in front of them if they manage to get onto those PR programs. Similar thing for cardiac rehab, it's that improvement in the quality of life for those patients. Sorry, would you move on? Thank you. So this is the national target. So there is a national plan for respiratory clinical networks, and within that there is a national plan around pulmonary rehabilitation. So the NHSE and NHSI aims to increase the number of patients who would benefit from increasing referral rates to PR from 13 to 60% by 2023. I hadn't realised when I copied and inserted that 2023 is in fact 2 months away. I did go to look at the data that we can get off fingertips, and there's a COPD cough, and I looked at what it is for our area. And for Humber and North Yorkshire, so this is for individuals who had COPD, in 2021 it was 25% had received a referral into PR services. Pre-pandemic it was 42%. So we still have some way to go. I think the difference is, and going back to some of my, because I still support cancer programs, in cancer the effect of the pandemic was dramatic, but there has been a national push, weekly meetings with the national team providers about getting referrals back in, about getting treatments on board. And yes, there is a push around pulmonary rehabilitation, but nothing like the press, and I use that with a small p, not a capital P, that there is around pulmonary rehabilitation for our patients. And so I think that is starting to gather pace, and we'll come on to that later. If you could go on to the next slide there. So that's it, lovely, thank you. So again, the national objective, sorry, I'm in your eye line, I'm sorry, there's not much I can do about that, is to improve the delivery of pulmonary rehabilitation through case finding, prioritisation and streamlining. And it's about personalising those pathways of care in supported self-management and education. That's what the national team wants to see. And that's part of why we have this requirement to not just produce a 5-year strategy for pulmonary rehabilitation, but to implement it. Thank you. So, in August, under a very short time frame, all areas, all ICBs, were asked to draft 5-year development plans for pulmonary rehabilitation services. Probably not the best month to try to produce something at pace, and it would be fair to say that there were lots of furtive calls trying to get some input into the plan. But these are just some of the highlights from our draft plan. And normally, when I see plans and strategies in the NHS, this is just a personal comment, I have heart sink, because I've seen so many plans and strategies in the NHS that are kind of in fashion 1 minute and drop off the next. But this one I feel quite confident about, not just because I've wrote it, but that gives it a good start, I'll take that. But because it means something, and I think it means something to the individuals, both providers and commissioners of pulmonary rehabilitation services, and to their patients. But there is a groundswell of enthusiasm for improving pulmonary rehabilitation services. The first statement about comprehensive coverage is to make sure that everybody, no matter where they live in Humber and North Yorkshire, get access to pulmonary rehabilitation services if they are appropriate. And that is really important. The second is about the quality of services. The national drive is that all pulmonary rehabilitation services should be accredited, and there is a national accreditation scheme. And there are some challenges around that, particularly where you've got rural areas where they tend to be smaller services, and trying to get those services accredited will be a challenge, but we're working with the national teams on that. Making sure that pulmonary rehabilitation services are embedded, and I'll come back to that in a minute. Workforce. There isn't a clinical network that I've been involved with that doesn't have workforce issues. And it cuts through, I suspect, most of the NHS. But it is difficult to recruit qualified, competent, capable workforce in this area of work, in this area. And part of where we need to go is to work out how we can sort out some solutions which are implementable for Humber and North Yorkshire. And finally, that last point is about making sure that what we do, we can measure and we can feed that back into the services. And there is the development of a national pulmonary rehabilitation dashboard. We have talked about COPD. And what I wanted to do was just describe here what the relationship is for COPD and pulmonary rehabilitation. It is closely associated with deprivation, is COPD, and we've got a map next that will show that. And smoking prevalence is closely associated with COPD. And COPD is the second most common reason for hospital admission. What I'm trying to say here is that because the largest proportion of individuals who make up the patients accessing pulmonary rehabilitation, if we mapped them, it is likely that they would map to those highest levels of socio-economic deprivation across Humber and North Yorkshire. And in turn, they would map to the highest incidence or prevalence of smoking. And with the presentation that follows me is around some of the work that the NHS are doing around smoking and smoking cessation. So basically what you're looking for on this map, which is about the prevalence of individuals on the COPD registers in primary care, you're essentially looking for the bright red or orange dots, gets very sophisticated this, on either the black or the grey areas. And you will see there Grimsby, Scarborough, Hull, Bridlington, are some of those areas where we've got this overlap between smoking, COPD and pulmonary rehabilitation. But you will know as individual clinicians that there will be patients in front of you who live in some of those other areas who have those issues. And so it's not always about following the map. So Get It Right First Time was an opportunity to ensure that services were in the right place for our population, not just our population, but nationally. And there was a Get It First Time report that included pulmonary rehabilitation. Whilst it didn't go into access to pulmonary rehabilitation in detail, it did come up with some numbers. And what it said is during deep dives, they'd heard that many examples where the services had insufficient capacity to cope with referrals, and that some patient groups, such as those with ILD, were being excluded. It also said that only 56% of people were assessed for suitability for PR and only 6% ultimately attended pulmonary rehabilitation. Sorry, could we go on to the next slide, please? So this is what Humber and North Yorkshire has inherited. So you may not be aware that the CCGs have moved across into one larger geographical area, which is Humber and North Yorkshire. And in a report which I took to the Humber and North Yorkshire boards recently, we've got 9 services cover our patch, from Scarborough, Hambleton, Richmond, Shire, Whitby, down to Grimsby. We've got variance between those organisations. Some have got service specification, so it's clear what they're providing, and some haven't. There's variance between service provision. Some are serving rural areas, some are serving urban areas. And what we have started is a conversation with the elective care board, with the directors of our organisation around pulmonary rehabilitation. The need to start that conversation was to make sure that people are aware of how important it was and how it served the needs of our population. And I don't think we should underestimate the need to keep raising the profile of these services, because we're going to need more of them, and we're going to need, our patients will need greater access to them, and that will need more money. So we have had some additional investment in services. We've essentially, from the national team, our area will get over £400,000 additional monies per year until 2029. It won't cover everything that we need for pulmonary rehabilitation services. It's likely that these services have been underfunded for a significant period of time, and so it's going to take more than those monies to close the gap. And that's part of the reason why we need to continue this ongoing discussion if our patients are going to get the benefit. I think this last point is the one that I want to focus on. We've got experienced clinical leadership within our clinical network, of which you are part of. But there's also a very eager leadership within our service providers, 9 of which I've referred to, but there's also eagerness amongst the commissioners to get this right. So we've talked about how come only 6%, and now clearly it's going to vary between CCGs, between the app places within our network. So where are we losing these patients? Well, some patients fall at the first hurdle. Those are individuals, and I stereotype to make the point. They may not have high expectations of their life expectancy or their quality of life, They may be late referring, taking themselves off to the GP. They may not follow or be compliant with what's recommended. And we've lost those at the first hurdle, and clearly that's quite a complicated area to cover. At diagnosis, and we've talked about some of the individuals in terms of getting the diagnosis of these individuals right in order to be able to refer them on to pulmonary rehabilitation services. But it's also about, do you as clinicians know how to refer into your PR services? Are you aware of what the PR services, what benefit they can provide for your patients? At the point of referral, so the patient might have accepted the pulmonary rehabilitation offering, but they don't attend the first assessment, and that's the last we see of them. Or they might start the course, but they don't finish it. These are not uncommon occurrences. The patient finishes the course, but isn't compliant with the lessons of the course. They haven't made the steps, to habit-forming steps, to improve the quality of their life. I'll run quickly through these. So, opportunities, and this isn't an exhaustive list. There is a focus on inequalities, and some of those we've touched on already. We've got the additional £430,000. We've got enthusiastic teams and services. We've started the conversation, and we've got proactive support. But furthermore, it is a national prioritised programme. We will have to account for how the monies are allocated, how the monies are spent, and we will have to get our services accredited, which is going to be a challenge, but that's where the national expectation is. Barriers, to name but a few. As I've said, 430k is not enough. Availability of workforce to do this is a challenge. There are many areas of transformation, not just pulmonary rehabilitation, but the 18 or 19 clinical networks have all got areas of transformation that they want to progress. And so we are effectively in competition, good, healthy competition, and someone is going to have to decide somewhere how to allocate those monies. National expectations are high, and it's, as I said, it's a nationally prioritised programme of work. So this is the last slide, and I was just musing through my mind what the future might look like, not in an H.G. Wells kind of world, but more like a pulmonary rehabilitation kind of world. And I've taken the liberty of speaking on behalf of clinicians and patients and services. So if I've got it wrong, then feel free to come up and tell me afterwards. So from clinicians' perspective, all patients who meet the criteria are referred on to pulmonary rehabilitation services. That the referral pathway is slick and it's fast and it's easy. That the patients regard pulmonary rehabilitation as important to their lives as a normal course of treatment. That it's not something that's offered at the end that they feel that they can just drop. And I appreciate there's lots of difficulties in tackling that. 100% of appropriate patients are referred and they all complete the course. And that the pulmonary rehabilitation services can provide a timely assessment. We have big backlogs at the moment, primarily arising from COVID at the moment, but some of those additional monies that I've spoken about have gone on to and will provide additional capacity. And that last point is really kind of on behalf of the staff, that services are fully staffed with confident, competent, and are working within available capacity. And I think that's really important, is the staff provide that frontline service, and we have to be as mindful of what the service is doing to them as what it's contributing to the patients. Thank you.
So we're going to hand over to James Owens. We're going to hear about something that's really, really important, which is around about the long-term plan for tobacco. I had to write down your job title because it went over about 2 lines. Project Manager, NHS Long-Term Plan Lead for Tobacco. It's incredible. I like the way that they word these titles. I was made the smoking champion in my trust, and I thought, well, does that mean I have to go and stand out front and sell tobacco? I thought it's kind of championing smoking, but here we go. And we shall hand over and hear why that's not the right thing to do.
Thank you very much. So I think I'm down for 15 minutes, but we'll see if we can get through it in 10, and then at least we've got some of our lives back. So thanks very much for having me. I'm Dave Jones. I'm a nurse by trade. I got into stop smoking services 20 years ago, and I'm going to make the case that there probably isn't anything more important that you can do with your time. So what is tobacco? You might expect a slide to say it's a burning combustible product, yada, yada, yada. No, actually it's this. This is the real thing that tobacco is. I'm not going to read out the things for you. You'll be all aware of these. Well, I'll read out a few. Nearly 40% of all hospital admissions, 40% of all respiratory disease admissions to hospital, 35% of all respiratory disease-related deaths. I think it's really important to look at this last point. The relative risk for diseases for current smokers versus never smokers, 24 times and 13 times in men and women. For ex-smokers, 9 and 4.5. So if you can get people off the cigarettes, that's what happens. Next slide, please. What's tobacco use? Well, we talked about this in terms of, we've heard, it's a chronic relapsing and treatable condition. We've heard about these conditions all evening. This is what tobacco is. It's not a lifestyle choice. It's not a behavioural thing that people, it's a disease of young people. It's a disease of the vested commercial interests of large companies. What does it do? Well, it's chronic in that 40% of smokers are still smoking around the age of 50. It's relapsing, that it might take 8 to 11 attempts before stopping. For some people, it's many more. What reduces that is the ability for us to provide good services. Support and medication increase the chances of success by up to 3 times. Behavioural therapies are well understood. Pharmacotherapy works well. And our stop smoking services deliver 4-week quits in excess of 60% regularly with all populations. I'll pop on a slide. So we talked about the long-term plan for tobacco. The NHS has this idea that we've got to do something. I mean, stop smoking services used to be in the PCTs, they went to local authorities. The NHS kind of didn't do anything for a long time on tobacco. It's just the truth. But now we've got the long-term plan. There's a significant investment being made in it. And what is it? It's saying that every smoker in hospital is going to be offered an intervention from an in-house team. So you come to hospital, very brief advice. You smoke? Great. Well, not great, actually. Let's have a chat about that. And here you go, some treatment. That this will be extended to expectant mothers and their partners. This is the first time I've seen anything where the pregnancy money can be spent on significant others as well. Fantastic, because if you don't do that, you know, someone else in the house is still smoking, very difficult to engage. And there'll be a new universal smoking cessation offer for people with mental health problems. People on serious mental illness registers is kind of the definition they're looking at the moment. That'll come in next year. Let's pop on a one. So, Humber and North Yorkshire, and for York, £1.3 million, not an insignificant amount of money for services. For York, this is 310, give or take, per year, and about 83,000 for maternity. And that's for tobacco treatment advisors and for nicotine replacement therapies and other such. We've kind of lost Champix at the moment, but we might get some other things in its place for those of you who know about that. We've got 4 staff on the ground, and we've got a maternity staff. It may be that the balance between pharmacotherapy and staffing is wrong. We can look at that as we go through. It may be we need more people to sit down and have conversations. It may be we need more NRT. Who knows? It's a new programme. It's a universal offer for mental health will start in April, and it's likely to be delivered between primary, secondary, and community care. Now, the important thing about the money is it's not going away. This money is there till tobacco's done. That's what the NHS has said. So we've probably got it. I mean, if we look at the current process, we've probably got that for maybe another, 20 or 30 years, unless we get our finger out and do something. Hopefully we've got it for another 10. So, we treat tobacco. What does this mean for NHS services? And this is in York. This isn't NHS services all around. This is in York. Nearly £3 million saving cost of readmissions, 1.75 fewer readmissions each year. About 900 lives saved per year, 24 beds created per day. That's treating tobacco. It's not insignificant what we're trying to do. Jump on one, please. It's a generational opportunity. Never has this investment been made in the NHS, never will we get this chance again. If we don't make the best use of this now, it's not going to come around again. This will be it. We'll be, look, why didn't we do that? Why didn't we cure tobacco when we had the chance? You've got the chance. This is it. You know, contribute to reducing smoking attributable hospital admissions by 1/4, cancers by 1/2, and respiratory diseases by 2/5. Bottom line, that's what we will do. Save 75,000 lives a year, which means we can take up new hobbies, consider a career in teaching, you know, tinker about in the loft, whatever it is you want to do, but only if you get involved. I was thinking about this earlier on. People say we don't have time to treat tobacco. You don't have time to treat tobacco because you don't treat tobacco. If you treat tobacco, you've got all the time in the world. You can do whatever you like, but treat tobacco first. And if you do that, all of those people suddenly go away. Let's have a look on. So we get an offer of support during a teachable moment. We access tobacco dependency services within hospital, continuing care, which is shorter stays, better recovery, less frequent admissions, less frequent readmissions, and longer, healthier lives. You'd guess those, wouldn't you? I mean, I'm not telling you anything that's unusual. Who's made all that up? This is what happens when we treat tobacco. But it only happens if we treat tobacco. You can see the theme here, can't you? Carry on, please. So, all smokers or recent ex-smokers are identified at admission. If you return, are you a smoker? No. Stopped smoking 2 days ago, so I'm going into hospital. Still a smoker, but not a smoker in their mind because they stopped 2 days ago. So anyone who's smoked within the last 4 weeks, still a smoker, because actually we know it's a chronic and relapsing and treatable condition, and if you're not smoking now, it's likely that unless you've had a course of treatment, you're going to go on to smoke in the future. So let's get engaged with these people. NRT provided, where required, as soon as possible. Walk in, you're a smoker, okay. Have you thought about, the hospital's smoke-free, we'd like to help you with that. What product have we got for you? Have a little look, da-da-da, there you go, prescribed, done. Yeah, something in your hand straight away. Shows the urgency, the importance of doing this. Or you're a smoker, okay, yeah, well, I'll get someone to prescribe something for you. Not bothered, are you? Oh, that's really important, let's do that for you now. Similarly, when you find people who are smoking, let's instill a bit of urgency. Oh, you're a smoker, right, I'll refer you on to somebody because you should stop. You're a smoker, I'm concerned about this. Do a carbon monoxide reading, very simple to do. Your carbon monoxide reading is concerning. I would like you to see somebody. Much more compelling than, I think you should go and speak to the stop smoking nurse, see you on the way out. In-house dependency teams, tobacco dependency treatment advisors, visit patients on ward. Different to the community service where it's predicated upon a quit. You come along to the stop smoking service, we can only see you if you're prepared to set a quit date, and then you're going to take some medication, and then if you don't make you quit, then we'll restart you. But in the hospital, temporary abstinence. You've come into the hospital, you've not come to quit. You've come because you broke something, or something's worrying, or something's wrong. You've come for that. Oh, well, if while you're here, you can set a quit date and you can stop. No. You come to hospital, it's a smoke-free hospital. We want to support you in being smoke-free while you're here because that's really good for your recovery, that's really good for your treatment, it's good for X, Y, Z. And to do that, we're going to provide you with some nicotine replacement therapy. Let's talk about what that looks like. There you go. Okay, I'm going to get someone to come and see you on the ward. Yeah? Recommend recorded outcomes then. We're a 28-day post-discharge quit. So what happens with these interventions we do, whether it's temporary abstinence, whether it's a structured quit attempt, whatever, what happens 28 days later? Because we know if someone makes it 28 days, they're 5 times more likely to quit. We also know we can look closely at the interventions that we've done. Temporary abstinence, what effect does that have on just giving some people the time, maybe 3 or 4 or 5 days without tobacco that they may never have had an opportunity to do in their lives? What does that do in the realisation I can do something? How do we then feed that into care that has a real and lasting effect? The universal mental health offer is likely to be around the traditional 4 and 12-week quits, as is the maternity offer. And the data's not the same, so we're not measuring the 4-week quit outcome that stop smoking services in the community do. We're measuring the 28 post-discharge quit, so we can look at them as different data sets. Please, next slide. So we'll be fully established by March 23. That means that every smoker who's identified within a hospital within York and Scarborough, within Hull, we're established at the moment, specifically just looking at York and Scarborough, but this process is through Enlag, Huth, Humber, Harrogate District and York. York's the third to go. Humber and Harrogate District will follow. Enlag and Huth have started already. So by March, every smoker in a hospital is identified will be provided with a brief intervention and referred for support should they uptake that. And it's our job to make sure the uptaking of that is a good offer, you know, and we'll talk a tiny bit about that as we come through because it's very easy to do, and that those people who are identified are able to receive support there and then. That's fully established. We're going to do that. This is what will be happening. It's not an option. You know, we can't not treat tobacco anymore. We should be preparing people. GP, you're going to hospital. Okay, fine. I'll do the referral. No. Hi, you're going to, I see you're smoking. The hospital's smoke-free. I'd like you to consider stopping smoking before you get there because it'll make your journey while you're in there easier, and also it's really good for you to do. So let's get something happening around that. Yeah, can you go and see a community service, however that looks. My pre-assessment clinic appointment. We've done a carbon monoxide reading. That's quite concerning. Are you still smoking? Let's do something about that. If the first time a person discovers the hospital smoke-free is when somebody turns up at the bedside and goes, hi, you want to quit? We've lost a huge amount of opportunity to prepare the person to experience a smoke-free care than if we just wait until that point and then suddenly, with all the rest of the stuff that's going on in hospital, they then got to go, I've got to quit as well. Difficult, isn't it? We've got continued year-on-year funding, and the setup and delivery of the universal mental health offer, as I said, is our next big challenge, which is starting in April. Slide on. So we want a programme developed with a modular approach. If it works in one place, it should work in the other. Where you go for treatment, it shouldn't look any different. We should have this idea of a Virgin Atlantic, you know, treatment that you get picked up by a chauffeur, you get taken to the first-class lounge, handed some NRT, put on the plane, flown to your destination, smoke-free, da-da-da, get off, taken to your hotel, not Jet 2. You don't have to find your way to the airport, and we'll maybe move you through a baggage lounge, and you have to wait, find your stuff, and then you've got to get your own taxi. We've really got to think about this being a continuous journey for people. It's a chronic, relapsing, and treatable condition. People are going to fall off the wagon. How do we help them get back on? We get back on by showing we care every time it happens. I'm not going to go through these. I mean, this is just the kind of things that you'd expect to have in a decent working system. I'll not bore you with this. More important things to talk about. Next slide. Quit Together. So we're branding this as Quit Together because it isn't just the job of one person. It's not just the job of the smoker to stop smoking. It's not just the job of the clinician to provide very brief advice. It's not just the job of the tobacco team to provide good quality interventions. It's everything. The NHS is going smoke-free, staff, patients, visitors, the lot. Quit Together we're looking at this as being the universal. When someone thinks about stopping smoking, it's Quit Together. Let's go to the Quit Together webpage. You're thinking about stopping smoking. Have you heard about Quit Together? That's where we're trying to get to with this. Again, one message, many voices is the important thing. Why are we still talking about what the right message is in terms of tobacco? We know what we've been doing. Smoking kills in 1998. First stop smoking service in Spearhead PCTs in 1999. Peter and Doll's link between smoking and lung cancer. The Surgeon General report 1962. You can go back and back and back, and we know what tobacco does and we know how to treat it. Yeah, I'm stood up here telling you, look, what's going on? What's going on is we need one message, many voices. It's a chronic, relapsing and treatable condition, and we can treat it. Next slide, please. And we treat it using very brief advice. And it's the idea isn't that you have to go into every single detail with every single smoker and discuss the whole thing there, and then it isn't. It's simple. This is very brief advice. Everyone can do it. Yeah? If you smoke, the best thing you can do is to stop. The best way is with medication support, and we can provide that. That's it. Non-judgmental, not difficult to do. You need to know where to refer and how to refer, but you can do that. That's 10 seconds. If you smoke, the best thing you can do is to stop. The best way is medication support, and that's available for free. I'll sign you up. You don't need to be a specialist in stop smoking to do that. You just need to remember these 3 lines and do them regularly. And if you do them regularly, people will get used to, oh God, they're concerned about, oh God, and they're concerned about it as well. Oh, flipping heck, maybe I should be concerned about it. But not take up all of your time doing it. Treat tobacco. This is treating tobacco as far as the majority of people are concerned. The tobacco treatment team, they can do all the rest of it. If you smoke, the best thing you can do is to stop. The best ways of medication support is available for free. I'll sign you up. Next slide. There's the references for the thing. Thank you very much. Hope I've got the message across that we have got one chance to do it, and the chance is now.
Thank you very much. And I think a very clear message and a really, really important message, because we absolutely need to do this, don't we? I mean, it's more important than anything else that we've talked about this evening, and that's not to do down any of the other talks, of course. But if we manage to stop people smoking, of course, we wouldn't have COPD largely. We wouldn't need to diagnose it. We wouldn't need to treat it. And the same goes for a number of other diseases. So really, really important. That now comes to the end of the streamed session, where we're joined with Hull. So just before we close off, I do have a message for both sites, which is around about feedback. So at the end of the session, you will be sent a link through probably within the next 24 hours. It's going to be Slido again. It will give you very quick 5 feedback questions, which we ask for. And once you've submitted that with your email address, then you get the certificate. So it is very much if you help us, we'll help you kind of affair on that. So with that, thank you very much for Hull for joining us. We're going to... Oh, you missed it, Vicky. I said it. We're going to say sign off with Hull. Helena will chair the last sessions in Hull, and I'm going to hand over to Latif for the final sessions here, covering spirometry and pheno. We are about 15 to 20 minutes behind. I'm sure Latif has factored that into her planning. All right, there we go.
Yeah, I got the pressure on. Thank you so much for joining us this evening. My name is Latif Hardek. I'm the respiratory nurse consultant and respiratory clinical research lead, and I've been the clinical lead across York and North Yorkshire for the PathFino project up till recently. It was only a year-funded project. I'm going to give you an update on the spirometry. As we all know, spirometry is not always simple. Some things in life are simple, some are complicated. Certainly, spirometry it has been very challenging in primary care and secondary care. In the last 2 years, how we diagnose and manage our patients. Next slide, Vicky, please. It's okay, no worries. Yeah, next slide, please. Okay, we got to remember we have the patients in front of us. When they have incorrect diagnosis, negative impact on patient health and well-being. They end up having inappropriate treatment inhalers, burden on healthcare provision, and pathway of missed opportunities for the patient. It is very important to get the diagnosis right at the first time. Next slide, please. Okay, I'm going to go back just pre-pandemic, and if you look at on the right side, the graph. This is the graph, basically percentage of patients with COPD on GP register in whom COPD diagnosis being confirmed with post-broncholator spirometry. If we look at it here. Basically, we were doing really great job in the primary care. We were carrying out quality spirometry, diagnosing COPD in GP practices. If you look at it over there, we have got the national mean is 80% over. We were diagnosing COPD, providing them quality assured spirometry. 80% and over. There is no variation when you look at this 2017 and 2018. Actually, in York is 82%. Harrogate was doing better than 85%. Humboldt and Richmond is 83%. We were providing that service to our patients. We were doing the diagnostic spirometry, which is 80% and above. Which means we had the devices, we have the skilled staff in our GP practices. What what has changed? We had the a pandemic, but what I'm trying to say is we were providing this quality assured spirometry 80% over, but we were still getting 30% of the diagnostic wrong. Maybe it is time to think how we can improve this diagnostic in our practices. Next slide, please. We have obviously funded 167 fully funded places for spirometry under the FINO project, funding, and 69 reporting refreshers is being provided, and 72 places we provided the refresher training. Where do we go now? Where do we go from here? We have obviously we are getting we were doing 80% of the spirometry in GP practices and getting 30% wrong. Now we can think about how we can improve this one, and how we what is stopping us, how we overcome these barriers, and how we can get through our big long waiting list. Now we have the clear guidance from PCRS, ARTP, IRNS, and the ARTP is giving a clear guidance the fact we can carry out the spirometry in GP practices. We don't need this fancy airflow extractions. And as long as you got the room, you can ventilate it windows, you can restart the spirometry if you haven't already started. Next slide, please. What you need to consider is obviously you need to have the symptomatic approach. If you haven't restarted the spirometry in your practices, you can probably think about it as a practice level or the PCN level. When you have this long waiting list for spirometry, work out your waiting list, and picking and choosing which one you should go. We should put that to list your top of the list, and again, information gathering. Is there any of the patients needs any bloods, chest X-ray? Get them done before you call them for the spirometry. And in my practice, obviously, I have already started doing spirometry. I always give them appointment within a week or 2 weeks, and they know what to expect. You can send them information letters via Accurex or via post, and I give them a call or text message within 24 hours, so you are not going to have DNA hiding. You want to have a slot filled up because it is 4 to 45 minutes. You want to make sure that patient is coming. If they are not coming, any reasons, and you can call the next patient. You got to review your clinical room, team, training needs, because you need to ask your nursing staff if they are confident and comfortable to carry out the spirometry, or do they need any training needs. You want to provide that. And infection control, like I said, you don't need the airflow extraction in your rooms, but you need to have a bigger room with the windows you can ventilate, and no follow-up time required, no lateral flow tests needs to be carried out. And this nursing, again, it is however you feel comfortable with surgical mask, FFP3, FFP2, and the apron, gloves, visor. And obviously for the patient, when you are calling them within 24 hours, you can check any symptoms, or there are anybody within the family has got any COVID-19 symptoms. You want to just minimize the risk when they are bringing these patients in. Obviously, hand sanitizer, they are going to hand gel before they handle your equipment and afterwards. And know your spirometry, because this spirometry has been in the cupboard over 2 years, and you need to get them out, to familiarize yourself, and calibration and verification. Patient preparation, obviously, you need to call the patients. They know what they avoid, how they, what to wear. And when they have the chest infection or COVID-19, they need to let us know, there is no point patient coming and you are not able to carry out that test, because they need to be recovered 4 weeks post at least from the chest infection and COVID-19. And if you haven't already started running the spirometry clinics in your practices, have a try run with the small numbers first, and to see how you do, and you can increase the numbers later on. But it is it is time to restart. Obviously, again, contraindications like I spoke. When you are triaging your patient screening, make sure they don't have chest infection, they haven't had recent cataract operation, or they haven't had the operation, because you don't want to lose that slot. It is really important. No DNAs, you need it. Next slide, please. Okay, it is obviously, I am going to prioritize my spirometry list. I got big waiting list, long list for the spirometry. I'm going to be pragmatic. And this is Jonathan. He's got natural cough, wheeze, breathlessness. He's got family history for asthma. He has got atopy. He never smoked. Yet guidelines says we need to do 2 objective tests. We got obviously good clinical history. 2 objective tests. We got FeNO now each practices, and we got peak flow. Guideline says FeNO and the spirometry, post-bronchial spirometry, but we are going to be pragmatic. We are not going to offer that slot to Jonathan, and we are going to do FeNO and peak flow diary to confirm the variability, and the asthma control tests, and bringing patient back, just listening his chest, whether if you hear that wheeze, record it, and doing bloods and chest x-ray, you can confirm the diagnosis. And if you are in doubt, obviously this is clear picture, if you are in doubt, you are going to put that patient back on the spirometry list. Next slide, please. I'm not going to go through this one. Mike has already gone through. This is the one respiratory network we have created. I am happy to share the link with you. Next slide, please, Vicky. Okay, this is Irene. Obviously, she is 52 years old. She has got chronic productive cough and shortness of breath since 2019. First visit to a GP practice is 2019. She was given antibiotics and prednisolone in January 2020. She's a smoker. And obviously, brother and father have COPD. While she had obviously during pandemic, we didn't get the spirometry first. We've done the bloods, chest x-ray, pro-BNP normal, blood eosinophils 0.1 until 0.2. She had 4 consultations over the phone during pandemic with the GP, and obviously breathlessness has been bothering her rather than cough, because she says, I smoke, that is smoker's cough. And telephone consultation during COVID, the SABA given obviously was put on the repeat, 14 loss of SABA inhalers in the past 12 months, which is really high. And this is the patient I'm going to put through to my spirometry list on the top. I've been recently ERS and PCRS meeting. It is 40 years over, ex-smokers, smokers, giving you the COPD symptoms, you are going to put them in the list. If you have got, recently diagnosed suspected COPD patients, you are going to bring them back to have the diagnostic spirometry to confirm the diagnosis, because you don't want them patients on the labeled as a COPD and they haven't gone to confirm diagnostic test. And I'm not going to bring the asthmatic patients already being asthma treatment, being controlled. There is no need to stop the treatment and do the diagnostic spirometry for the asthmatics. Next slide, please. Obviously, spirometry, it has improved the quality of care, diagnostic confidence and accuracy, and they reduce the visit to practice and exacerbations, because if we don't get the diagnostic right at the earliest, these patients are going to keep coming to us, taking our clinical time. And we can achieve the cough and achieve the IAF indicators at PCN level. Next slide, please, Vicky. Okay, it is really important we take steps to restart spirometry in primary care. Currently, it is estimated we have over 2,500 patients waiting for spirometry. The more undiagnosed patients are in the increased risk of exacerbations and deterioration with the increased demands on the system. If you haven't already started, would urge you to come to speak to me or discuss the PCR document CQC or BMA on spirometry. A systematic approach is really good because you are going to picking and choosing appropriate treatment, appropriate patient to offer that test to them. And yes, it is not straightforward path. It is a long way to go, but we can do together to sharing ideas, experience, and knowledge. Obviously, I've been fortunate enough, I only didn't do the spirometry only 3 months. I've done it in hospital, PFD Lab Royal Hallamshire Hospital for 2 years, and in June I started seeing my patients face-to-face in GP practices. I see between 5 to 10 patients a day and carrying out spirometry. Okay, thank you. This is my spirometry slides. I hope I have managed to do it within 15 minutes. Okay, any questions I'm happy to take quickly before I go to Fino? Okay, thank you. Sorry, I had the pressure on. Okay, what is Fino, where Fino fits in asthma and primary care? Next slide, please. Okay, I'm not going to go through this asthma definition. Obviously, we need to have more than one symptoms and the variable airflow obstruction. But what I want to touch on is the airway inflammation. Because in primary care, we haven't been checking this airway inflammation. The only way we are going to check the airway inflammation with using the Fino. Next slide, please. Okay, we have, obviously, the airflow obstruction is the spirometry. Peak flow, we can detect the variability, and the clinical questionnaires, we ask the asthma questionnaire, asthma control questionnaires, and the airway inflammation is we are going to now focus on with the Fino devices, which we have been all provided. Next slide, please. Okay, why Fino? Evidence shows that 30% of our asthma diagnosis may be incorrect. Okay, Fino is a marker for eosinophilic inflammation, which is another piece of asthma jigsaw not detected with spirometry or the peak flow. Fino is useful diagnose an untreated eosinophilic inflammation, and it is useful for diagnosing the eosinophilic inflammation. At the same time, it gives you what type of asthma it is. It is type 2 eosinophilic inflammation. And Fino level can help to give the clinician and the patient confidence that the eosinophilic inflammation is present, this is correctly untreated. This may require better adherence, improve the inhaler technique, or more effective dose for ICS therapy. We got 3 devices, obviously Bosch, no breath, Fino, no breath Bedford, courtesy as a Fino Niox. We have got 2 of them being approved by the NICE. It is the no breath devices you got in practices and Fino Niox. Next slide, please. I'm not going to go through the NICE asthma or BTS sign guidelines. Yes, they do. They don't. NICE goes for evidence and the cost effective. They want 17 years and over they are asking pheno and spirometry. But BTS is where, next slide please. BTS is where the intermediate probability of asthma recommends the pheno and the spirometry. Obviously, like Mike mentioned about, they are going to join together hopefully next year, going to have the same guidelines joined together. Next slide, please. Okay, what was pheno? I mean, I already said it just, it is used for diagnosis and what type of asthma that your patient has got. What is they are eosinophilic type 2 eosinophilic asthma is going to respond to the ICS, and you can help check the adherence and the biologic therapy. There are lots of things we can do with pheno. Next slide, please. Okay, this is the slides. It is on Wessex website. It is quite useful. I send this one to my patients via Accorex. You can send it so the patient knows what they expect and what they avoid, because there is no point you patient turning up, they got chest infection, cold and flu symptoms, or they have consumed beetroot, celery or coffee, because you are going to waste that £3.50 consumables mouthpiece. They need to avoid, obviously, exercise, make sure not rushing to running or rushing to GP practice. When they come, the pheno is going to be high. When they have hot drink or caffeine and cigarette, they need to avoid for an hour. And the one is the nitrate, the vegetables, green vegetables, celery, beetroot, lettuce, spinach, kale, they need to avoid for 3 hours because it will increase the pheno levels. It is really good to send. I am happy to send you the link you can have. It comes with 7 languages. Next slide, please. Okay, measuring pheno. I'm going to actually show you how to measure the pheno. It will take you on a second. But what it is, the technique is only needs 1 crack blow. Patient usually get first time, second, or if not, third time. You can have 8 attempts, but it doesn't require 8 attempts at all. Basically, they breathe out. You want to breathe out the nitric oxide, and they breathe in, and one steady blow through the tube. Adult is 10 seconds, and children is 6 seconds shorter. This is no breath device, is the breathing, lips around the mouthpiece, and the blow out, steady blow out. And the phenoniox, obviously, it is breathe in and breathe out through the tube. I'm going to demonstrate after I finish with my slides. It is very simple. Okay, next slide, please. Okay, I'm not going to go through again. This is the Mike mentioned, and it will be Futures NHS website under Pheno project. We will be happy to share the link with you. Next slide, please. Again, I'm not going to go through these slides because these pheno machines do come with the rainbow charts. Then you know what is low pheno, intermediate pheno, where you need the thinking zone, and the high pheno. Next slide, please. But please, it is really important to remember that objective tests can be normal in asthma, and particularly when treated and or symptom-free. In the event of normal test, consider repeating the test when symptomatic. Or if any doubt, refer them to secondary care team. Don't sit on this patient, please. Thank you. Next slide, please. Probably Caroline wouldn't like me to say that. Okay, these are real patients. These are York and North Yorkshire. Okay, I got Yasmin. Patient name is, I've changed the patient name, obviously. Yasmin is 20 years old. She had asthma all her life, asked to come for review due to collecting 21 salbutamol canister, in the last 12 months. And as well as she's collecting 8 Clenil inhalers. Works as healthcare assistants, lives with the parents, and they all have asthma. They have got a dog, and Yasmin has got Evermist nasal spray with good technique. She takes it regularly, and she takes antihistamine. Since the pandemic, she's struggling with anxiety due to pressure from Merck. This lady had the asthma questionnaire sent through the Accurex, and it is asthma control is 24, well controlled. And she had another telephone call with the nurse over the phone. A patient said, yeah, everything is controlled. I'm using my inhalers. This patient was controlled over the phone. But she had one loss of chest infection, which she was given antibiotics and prednisolone. Okay, I have carried out pheno. It's 124. This time she was nighttime waking. She used to bike to work, and she used to go to gym. She stopped doing everything, but it was just normalized. I asked her, are you sure you are using your brown inhaler? She said, yes. So I might have forgotten 2 days. Then I said, are you sure 2 days doesn't make difference? Then a week, then she admitted she hasn't been using her clonal inhaler because it made her cough. She has been managing her asthma with salbutamol inhalers. And the reason she is getting, that's why asking the right questions is really important. The reason she was getting her brown inhalers is her previous practice stopped her reliever inhaler because she wasn't collecting enough preventer inhalers. Therefore, she was getting both of her inhalers, but not using her clonal, and just managing the asthma with the salbutamol inhaler, because it just made her cough. Looking at her medical notes, actually, she has been treated with thrush. And we have given the choice of inhalers. She has taken exactly the same 100 microgram, just dry powder, which she's happy and comfortable to use. She came back 6 weeks later. Her pheno is 34. She's feeling much better, improved, and happy. She didn't realize how the things being bad. She was waking up during the night as well previously. Next slide, please. Okay, before initiating any new therapy, practitioners should check compliance with existing therapy, inhaler technique, and eliminate trigger factors. Obviously, this girl didn't have triggers. Yes, she had a bit of anxiety. She would have been using salbutamol more, but there is an eosinophilic inflammation there. And we need to ask, we can't really presume they are collecting their inhalers. We are seeing the prescription history. We need to ask whether they are using the inhalers they are collecting. Next slide, please. Okay, this is Mike, 52 years old. Asthma diagnosis made 24 years old. He's on clonal, and he had increasing symptoms over 6 weeks, occasional night waking, and needing rescue inhalers most days. He just attended for the normal research study visit where he gets his routine asthma review. He hasn't attended because his symptoms getting worse. Okay, he's got good inhaler technique, good adherence, no new triggers, no recent upper respiratory tract infection. I carried out the pheno, and his pheno is 89. Symptoms were in control. The type 2, this is given the history suggests type 2 inflammatory symptoms. I increased the ICS. And you may think why I haven't added LABA or MART. Obviously, this patient he has got the eosinophilic inflammation there. It is 89. Me adding on LABA, it will just give a bit the reliever, but inflammation there. Therefore, I increased the ICS for this patient. And 6 weeks later, he came back, pheno is 27, symptoms control, not nighttime waking, or hasn't used a salbutamol at all. Next slide, please. Okay, this is the one for the diagnostic, and Caroline is 51 years old and has got the history, and yes, there's an ex-smoker, and the teacher knows not certain family history as adopted. She had eczema as a child, and we carried out, obviously, pheno 70. We've taken the good clinical history. Obviously, please make sure, don't look at the pheno numbers, look at your patient, have a good structured clinical history, signs and symptoms. Pheno 72, we've been pragmatic, we didn't do spirometry, bronchodilator reversibility, we did the peak flow variability confirmed. We have given ICS and suspected asthma coded, and 6 weeks later, follow-up pheno is 21. And we coded this patient as asthma, giving the asthma management plan, inhaler technique. Next slide, please. Okay, this is the patient we referred the secondary care. She is 45 years old female, asthmatic since childhood, taking high dose of ICS LABA, Spiriva. She couldn't tolerate the Montelukast due to anxiety. She had 3 courses of steroids in the last 9 months. Eosinophils is 0.8 to 1.2 for many years. She has got multiple allergies, IgE 586, FeNO is 186. Basically, the patient has got the eosinophil of 0.8 to 1.2, and the FeNO is 186. Patients, I am hot asking for help, because you need to help this patient. It is really, attacks is about to happen. And obviously we carried out the spirometry, and this patient has been referred to secondary care. But please, when you are referring these patients, put all your history, signs and symptoms, all the objective tests you carried out, prescription history, adherence, then they are not going to come backwards and forwards. In the meantime, we got the patient losing that time. We need to get this patient referred to secondary care with the full package, because we are privileged. We've done carried out the objective tests. We got the prescription, the way they are collecting their prescription, and we know our patients whether they are using their inhalers, which secondary care they don't. Next slide, please. Oh, that patient, yeah. And this is the Jane, 54 years old lady. She's asthma COPD develops. In the notes, this is the. This patient actually had 6 lots of antibiotics and prednisolone, 18 lots of salbutamol within 12 months. And she was on Chirimbo with volumetric spacer with good technique and adherence. Previous year, she was on Fosday 206, Tiotropium, and Montelukast. And she had 4 lots of exacerbation and 12 lots of salbutamol canisters. But Montelukast, obviously, she couldn't afford to buy. She was paying her prescription. She couldn't afford it, and with the inhalers, she was lasting it longer. She wasn't taking it regularly. Therefore, they said, "Oh, it is not controlled. Let's put them triple therapy, Chirimbo." And I have carried out the FeNO 108.9. And this patient struggling with symptomatic, and we put her Fosday 206, 2 puffs AM and 2 puffs PM, MRC 6 weeks later, we came back, no nighttime waking. Patient hasn't used salbutamol at all, FeNO is 30. And she has improved the VAS score, and the quality of life is improved. Next slide, please. Okay, this is Emilia. This will be last one page. Emilia is 8 years old, several A&E admission up to 2 years old, and documented with a type illness, but none since 4 years old. And obviously family history of asthma, mild asthma under 2 years old, and she was given ICS and Preventer and the salbutamol post-hospital admission as an infant. Inhalers remains on the repeat, and she was only getting it winter time, but using it when needed. Preventer is using it when needed. And the salbutamol is at night when coughing, when uses 10 puffs with spacer. But the only reason the patient came to the GP practice is the persistence since going back to school in September. Not coded asthma, no asthma code. We carried out the diagnostic, FeNO 58, and peak flow diary confirmed the variability, which is positive. She's on the treatment, she's on asthma register now. Next slide, please. Okay, FeNO can be useful for stepping down as well. There is no point keeping the patient on high-dose ICS or high-dose ICS LABA. When you check the FeNO, it is a bit less than 25, and you can be just thinking to stepping down. When it is 25 to 40, that is thinking zone, just think about it. Obviously, when it is high, you check the 40 part per billion for adults and 35 for children. You need to think about it, what else is wrong. And the other thing is I have forgotten about the mention, which I missed that slide, Vicky, is if the patient has got rhinovirus, hay fever, they are symptomatic, and the tall men, they will have the high FeNO because they got big lungs, they produce more sputum. That's Caroline agrees with me. Sometimes because I have the tall man at the high FeNO. Next slide, please. Okay, I know it is costly, these mouthpieces, but we need to think about the environment and the cost. Correct diagnosis is the key to reducing the cost, improving outcome, and reducing variation in practice. I'm not going. If we do not think about the cost, we will not be able to deliver the good health care. Thank you ever so much for your attention, and I'm happy to take questions.
My name is Mohammed Mansoor, Manny for short, for those who know me. I'm a GP in the East Riding. I work at the Ridings Medical Group and I'm a partner there. Next slide please. I wear a few different hats. I'm the respiratory clinical lead for the East Riding, and I'm also the clinical lead to the Path to FeNO project. I'm also a GP trainer, and I'm also a tutor at the Hull York Medical School, and I'm passionate about everything respiratory. Next slide please. So, the most challenging conversation is in primary care at the moment is spirometry when it comes to respiratory. Hugely debated topic. What do we do? It's a minefield of such. So next slide please. So what I'll try to touch about is a bit of background. Barriers to starting spirometry has been a huge challenge. A pragmatic approach to how to get around these problems and how we can kind of restart spirometry within our practices. Next slide please. So before we go further, how were we doing? We were doing amazing. If we look at our data, this is the variation or the atlas of variation, the variation of percentage of COPD patients on GP registers who were diagnosed following post-bronchodilator spirometry. And this is from Public Health England data. If you look at this, looks like the climate change band. It's not. These are each line represents a CCG area within England, and what I've done is I've highlighted our area for the Humber, and we were doing amazing because that's the red line on the top is the national average, and we were all doing about 80% of our diagnoses were done in primary care for our patients, and well done. Primary care has done this, and if you look at our CCG areas, we were all pretty much very close to this 80% band, and from 2013 where we started up to 2018 we've caught up to that position, and all these diagnostic tests are happening in primary care. Obviously roll on 2019 pandemic, we all were asked to stop doing spirometry. Rightfully we did stop doing spirometry. Next slide please, John. So what's stopping us? Biggest risk was AGP at the time. We stopped, and we also had to deliver one of the largest vaccination programs in the country. Another challenge was we were asked to have limited number of patients within our practices. We were adapting to working remotely, and we must not forget most of vulnerable patients who were coming into primary care were afraid to come in for a diagnostic test, and we were afraid too of the risk associated with doing these tests. So in 2019 we had 2020 springtime we had a mandate from, well, let me rephrase, early 2021 we had a Public Health England document release saying spirometry was safe to perform because it was happening in a closed loop, and NHSE sent us a mandate saying no, now we should be starting to do spirometry in primary care, and primary care went on, hold on a minute, this is not safe because we've got evidence. It's not because it's happening in a closed loop. We know if it's done correctly, 50% of our patients are going to cough at the end of spirometry, and that is the true risk. And at that point we stopped doing spirometry and we held back for that reason. But not just that reason, it was all of the other reasons that I mentioned before. These are all contributing factors. So it's not just the infection control risk alone. Next slide please. So what's happening now is what I kept thinking. Why can't we start spirometry again? If we go on holiday, our patients are coughing. If they are in the supermarket, they're coughing. In our waiting rooms, they're coughing. When they come and see me face to face, they're coughing. And that's, times have changed. We have taken the right precautions. We have learned to live with COVID, and coughing is not the total risk factor that's stopping us from spirometry. When I put my partner's hat on, spirometry, cost of living crisis, expenses, staff need to be taken away from other services that they're delivering, and it's all of you who do spirometry or did spirometry know it's a very time consuming process. So I have to take staff away from what they're doing to do spirometry, and that affects other services I deliver. So it's trying to balance that is quite important with my partner's hat on. But how do I convince my partners, or how do you convince your partners? Well, if you don't diagnose your COPD patients properly, they're going to end up having exacerbations. And when they have exacerbations, they're going to end up calling you at the surgery. And they're going to have 5, 6, 10 appointments in the year. Multiply that by 25 patients, that's your access problem, especially coming into winter. So the better diagnosis you have, better control you have, less times they show up at the surgery, you're having huge reduction in demand for work. Next slide, please. So in 2021, we asked you, while we did the Path to Pheno project, on how you were doing this. Thank you for everybody who gave us feedback. 76% were not doing spirometry in primary care, and 10% following the mandate from NHSE had started spirometry. I belonged in the 9% group. I was thinking about, how do I get this off the ground? Next slide, please. So where do we go from here? So one of the conversations I was really afraid of having was with my nursing colleagues, because I didn't want them to do spirometry and get sick or have any problems. So luckily, Primary Care Respiratory Society, British Thoracic Society wrote a lovely document that gives us guidance on how we go about delivering primary care, spirometry in primary care. If you hadn't had the chance to look through it, please have a look through it. And it was at this point, Karen is not here today, she's one of our nurses who's doing spirometry in our practice. I was reading through it, I happened to speak to her, and she was tapped on my shoulder and said, I've been reading it through. We could put this together and make this happen in a safe environment and take all the precautions, and we kind of got our plan together. Next slide, please. Right, so I will skip this case very quickly. In short, this is Jonathan, who had come to my practice, who had very likely diagnosis of asthma. And we brought him back. One of the key messages I deliver is, if the patient comes in, I generally tell them, if they're not having an exacerbation at that point. Now, Jonathan was quite stable. The day he saw me, I told him, look, you don't have an exacerbation. His expectation was to get a blue inhaler when he came in, but we need to do some objective testing before we start to give you an inhaler. He had a 2-week trial of peak flow measurements at home. We also had access to pheno, and when he came to see me, had a pheno of 76 at the time. We started him on some ICS inhalers. Next slide, please. And we applied the North Yorkshire and Humber pragmatic guide to diagnosis of asthma. And when we did that, he was on the high probability category. So he had high pheno, he had a good peak flow variability, he also had a very good history to support an asthma diagnosis. So he didn't really need a spirometry to diagnose his asthma. So we coded him as asthma. You can code him as spirometry not required. You tell the patient, oh, you have all the features of asthma, we're going to start you on a course of treatment, and you get him on treatment and then review him to make sure he's stable. If he's not stable, then you've got spirometry if you need it. Next page, next one, please. Very short. Mark was the most shocking one. He came to me, when I saw him, was a repeat request for his 14th SABA inhaler. He was seen 2019, just before the pandemic hit, and with breathlessness, and he slipped through the net at that point, and he kept on requesting SABAs, remote consultations. It was put on repeat, and he carried on that way. Now, he was prioritized to have a spirometry within the surgery. And he had by that point, this year, he had 5 appointments for breathlessness, chest x-rays, blood tests, pro-BNPs, lots of different random tests for breathlessness. without actually achieving clear diagnosis, and he kept on using his SABA. That's all he got. Next slide, please. So we did a spirometry. Now Mark is running 5K park runs. He's taken it on board to kind of understand COPD because he's been given a clear diagnosis. He's on a LAMA-LABA treatment and very stable, and managing his condition by himself. And he's reduced the burden on primary care and the healthcare system. So it also improves the confidence, and you make less mistakes and you get the right diagnosis right. It also helps you achieve cough and IF indicators as PCN levels. So it's talking to your partners, or if your partner here, it's kind of thinking about how do we get this off the ground, and it can be done. And having a systematic approach, look at your registers, see how many patients there are waiting for spirometry, trying to chisel them through and see actually do they need one, have they had only one inhaler, and then do they actually need a spirometry being done. So you can reduce that list if you look down the list and go through it in a systematic way, and you can prioritize them. Checking your equipment, having a trial run, but if you feel that you need another talk on this or lunch and learn session, please let us know in the feedback. I'm quite happy to go through it in a bit more detail and have a bit of a deep dive and take things from there. Next slide, please. Right. Happy Place. This is, for those who don't know it, this is a lovely climb in Mallorca called Sacalobra, and it's a bit of a journey. It's going to be an uphill journey getting spirometry off at the practice. If you haven't started, you might have to speak to many different people. It's a bit of a windy road, but with a bit of effort, we can get our patients on this route and get spirometry started. That's me. Thank you. Thank you.
You do have any questions? Obviously, we're running a little bit, but we will stay behind. So if you have any questions at the end and want to ask any questions in regards to either of the local presentations, do let us know. Just out of interest, how many people are doing spirometry in primary care? Just started. Anyone not yet doing spirometry? So all the practices that are here are doing spirometry. Okay, so I'm going to hand over to Lisa Galloway. So Lisa is going to speak to us about fractional exhale nitric oxide testing, which has been rolled out significantly across primary care now. Lisa's currently doing her master's dissertation on FeNO. Hopefully you've all seen a questionnaire and filled it in for her, but send it back. So good luck with that, Lisa, and thank you so much for spending tonight.
So I'm just hoping to give a little brief overview regarding FeNO testing. I've been doing a lot of work around FeNO testing over the past couple of years. I'm hoping to gain a little bit more understanding of the importance of objective testing to support and promote an accurate asthma diagnosis, to learn the principles of how to perform an accurate and valid fractional exhaled nitric oxide test, and to gain an understanding of the role of FeNO testing in asthma diagnosis and management, and to understand how FeNO can also be used to predict a positive response to an inhaled steroid. Just the next slide, please. So asthma diagnosis or misdiagnosis is actually very common. It's thought to be around about 35% in adults and 50% in children, and that number has probably significantly risen because of COVID and the impact that's had on objective testing. Asthma should never be diagnosed on symptoms alone, and once we've started somebody on an inhaled steroid, it's actually very difficult then to make an accurate diagnosis. So trying to get that diagnosis before starting a treatment is actually very important. And the worry is that people can be started on a steroid for vague reasons, and that treatment can continue for many, many years, which has an impact on funding within the NHS, and it can cause harm to the patient as well. There's no single gold standard test for asthma, and I actually think that's quite appropriate because asthma involves many inflammatory pathways within the lung, and for that reason you do need to be able to look at different tests. Spirometry is very good, but spirometry, unless you're catching the patient when that they're exacerbating, they're unlikely to show obstruction on spirometry. So having other tests available to try and improve an accurate diagnosis is actually very important. And I think vital as well is taking a good clear history from the patient, being able to examine the patient, listen to the chest. If you hear a wheeze, that is very supportive of asthma, and that ability to complete objective testing to improve the diagnosis or improve the accuracy of the diagnosis, minimise patient harm through unnecessary medications, and protect those NHS finite resources. So I just wanted to just look at exactly what nitric oxide is. So a few years ago it was actually thought to be quite a bad substance, an environmental pollutant, and even a possible carcinogen and a precursor to acid rain. But then quite a lot of research started around the use around nitric oxide in the body, and it was actually it was these three chaps. Now I don't even want to try and pronounce his name. Yeah. So first show Murad and Ignaro, but they actually won a Nobel Prize for physiology or medicine back in 1998 for discovering that actually nitric oxide's role within the body is extremely important. It's a very important signalling molecule, and a lot of our cells in the body actually do produce nitric oxide, and the very best nitric oxide is very beneficial for homeostasis within the body. It's got many roles within the body. So what is the role of nitric oxide in asthma? So in the lungs, cells within the lungs, the nitric oxide production can actually be upregulated, and it was actually found by accident within a research laboratory that patients, or not patients, people working within the laboratory who had asthma had much higher levels of nitric oxide than people that didn't have asthma. So a lot of research began around nitric oxide and asthma, and it generally nitric oxide levels are higher in asthma patients than patients without asthma, but not always. It just depends on the endotype of the asthma and which inflammatory pathway is affected within the lung. But it is actually a very good marker of airway inflammation in many endotypes of asthma. So in asthma, nitric oxide is generally higher, and elevated FeNO levels are thought to be a marker of worsening airway inflammation and asthma exacerbation. And also it can be an indicator of asthma severity as well. So the higher the level of FeNO, or the higher the level of nitric oxide, is thought to be a good marker of asthma and risk of asthma exacerbation. So just looking at the NICE guidelines, so primarily we should be doing spirometry on patients to check for obstruction, because most endotypes of asthma, if you're catching that patient when they're exacerbating, they will show obstruction on spirometry. But like I say, the sensitivity of spirometry isn't always great depending on the patient's symptoms. So having the ability to be able to do a FeNO test to check for airway inflammation is actually a really good tool. Peak flow variability is good, but again it depends if the patient is exacerbating at the time, and doing things like blood eosinophil levels can also be a good marker of airway inflammation as well. So guidelines for children and guidelines for adults both say that we should be doing FeNO testing as a secondary test for asthma. And it's actually quite a sensitive test for asthma as well. Of the tests that we do, the sensitivity and the specificity of FeNO testing is actually really quite high. So having the ability to be able to use it is actually really important for primary care. Now, I just wanted to put this on NICE do say that for children we should be looking for a level of 35 parts per billion or more, and in adults it should be 40 parts per billion or more. This guideline is the American Thoracic Society, and they talk about an intermediate level as well. This is spoken about within the NICE guidelines a little bit as well. And I actually think this is also important for reasons that I'll just go on to talk about. But really, the higher the level of the FeNO, and the more confident you can be of airway inflammation. So, elevated FeNO, now I've already really said an awful lot about this, but it is a good predictor of a positive response to an inhaled steroid, because like Manny was saying before, if you've got inflammation in your lungs, then you need to give the patient a steroid to be able to reduce the inflammation. FeNO is also very good if you're going to be trying to prescribe in a tailored fashion. So if somebody's asthma is very well controlled and the FeNO level is low, a lot of the guidelines do talk about the need to step down in asthma. So if you've got somebody on a high dose of steroid, it's actually a really useful tool to be able to step them down and step them up as you need to. So just talking about things that might affect FeNO levels. So smoking can actually significantly decrease a FeNO level. Nitrate-rich foods can significantly increase the level. Alcohol can actually reduce FeNO levels, and caffeine can reduce FeNO levels. And believe it or not, some research that I was reading a few days ago, carbonated water can reduce FeNO levels, whereas still water wouldn't have any effect on the FeNO level. And generally speaking, men tend to have higher FeNO levels than females, and the thought behind that is that that's because men have larger lungs and they're producing more nitric oxide. So before doing a FeNO test, we really should be counselling patients, making sure that they've not smoked at least for an hour before they come for a FeNO test. Hot drinks, alcohol should be avoided before a FeNO test, and ideally they shouldn't be eating any nitrate-rich foods for at least 3 hours before a FeNO test. So making sure that we're giving out this information before bringing patients in is important. So I've got a couple of case studies that I'll just very quickly whip through. So this lady came to England. For the past 6 months, she'd had an intermittent non-productive cough, which was worse at night. Some intermittent shortness of breath, which was most noticeable when coughing. She was needing to stop at times when she was performing her day-to-day activities. She'd had a couple of courses of antibiotics that hadn't helped, and there was no history of any respiratory disease. She'd never smoked, and she was living in a council flat which had damp in the bedroom. We did spirometry, and that showed no obstruction. And a BMI was 34. So when we did the FeNO test, it was actually 88, which is quite a high indicator of airway inflammation within the lung. Started her on an inhaled steroid, brought her back 4 weeks later, and that FeNO level had dropped to 34, and the respiratory symptoms had improved. So this is a good classic case where you've got spirometry that's not been able to adequately diagnose asthma, but doing a secondary test can really help inform your prescribing decision and management of the asthma. Another one here, young lad, he's only 6 years old. He's had intermittent breathing problems, intermittent night wheezing, dry cough. He gets tired quickly when he's playing football at school. Never had a diagnosis of asthma, although mum does have asthma. He used to have eczema as a baby, and he still gets it a little bit, so he's got all the atopy there. He tried to perform spirometry, but he was just too young. So we did the FeNO test on him, and it was 42. So according to NICE, that is indicative of airway inflammation in a child, and we were able to start him on a low-dose steroid with an aero chamber, repeated the pheno 4 weeks later, and it had dropped down to 18. Symptoms have improved and he's playing football again. And just one very quick last one. This chap, sorry, he's very well controlled with his asthma, exercises regularly, he's on a Clenil 100, 2 doses twice a day, and he's very compliant. He's not had any symptoms of asthma for a long time. He's not used his SABA for at least 6 months, so do we need to change anything? Well, actually, this might be a good opportunity to do a pheno test, which we did. It's only 16, so we switched the Clenil to a Pulmicort, 1 dose twice a day. So we've reduced the dose of steroid, reducing the risk of side effects, bringing back 4 weeks later, pheno still only 18. So that is appropriately deprescribing in asthma. It's much better for the environment because he's no longer using an MDI, which has got a high carbon footprint, and it's reducing the risk of iatrogenic harm, and also protecting finite NHS resources. So with my lovely assistant, we're going to do a little demonstration, if that's okay. Very quick and easy test to do. Sometimes people do need to do more than one attempt with this test. Do you mind if I turn that round, Manu?
Yep.
You can't
Yep,
see it really, can you? So, sometimes it does take more than one attempt to get the right technique. Shall we pop it over there?
We'll stand in the middle. I can stand
Okay.
No,
Crikey,
here.
I'm forgetting this. There you go. Do you want to go there?
We're right in front of the
Oh,
Here we go. Okay.
right. So there's a control on this machine for children as well. It's a bit like a cartoon. So children tend to be very interactive with this, but for our Helena, we're going to do it on the adult. On the adult.
I hope I don't show myself.
Now, to begin with, she's actually going to suck through this as if she's sucking a drink through a straw. The reason for that is because if you're living in an area where there's high pollution, it might be that you've got a lot of nitric oxide in the breath that you take in. So the beauty of the Niox is, as you suck, there's a filter within the mouthpiece which is going to remove the nitric oxide. So you're only measuring the nitric oxide within the lung. So to begin with, she's going to suck through it. As she sucks, the balls at the bottom are going to light up orange. Oh, that's it. And then she's going to start to blow to move the needle here across a little bit harder, keep it there, 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 keep it there. Well done. That's it. First time, well done. And it literally, we're going to get a result in less than a minute. You know, this is how quick it is. So in an asthma clinic, if you're seeing patients and you're thinking that the symptoms are suggestive of asthma, it's actually a really good tool whether to step somebody up with the medication or actually step them down. And the beauty is you can bring them back 4 weeks later and you can check that decision. I mean, I've found it absolutely incredibly valuable.
For monitoring as well in terms of cost stepping down medication. So this is one of the ways that you can justify having the resource of the consumable. So we're aware that this has been rolled out across primary care, but there's difficulties in terms of who is going to fund consumables. So these are the things that you want to maybe audit and monitor, is that if you're starting to reduce medication, so reduce ICS use, don't stop please, but reducing ICS use, you will save money in the long term. And also patients with asthma are going to have better control with the implementation of this. So yeah, it is an important tool, isn't it?
So it's 8. You've not got asthma.
You're taking my inhaler.
Jolly good. Well done. So yeah, I mean, fabulous tool. Costs about £5 a test, that's all. And if you think of the money that you're potentially saving by making sure that you're only prescribing inhalers for people that actually need it, and it's such a valuable tool. Now I'm just going to see, I think I've more or less covered everything, but I'm just going to quickly double check. Apologies for keeping you. So just a couple of take-homes really. So, you know, misdiagnosis is very common. Symptoms alone aren't enough. The ability to do objective testing is so important, alongside that history taking, physical examination, and pheno, you know, it can be an indicator of airway inflammation and a predictor of a positive ICS response.
Fantastic. Thank you, Lisa. Huge thanks. Thank you so much. If anyone has any questions about, you know, just for transparency and balance, there is another device.
So we were going to demonstrate it, but it's not our time.
If you want to see the other device, we're happy to show you now. Thank you so much for staying behind and not all running away at the clock.
Thank you.
This is our first time streaming between two sides, which was incredibly stressful. Before you walked in, we had no projector working. So thank you for bearing with us. Hopefully you gained some insight. It's been great to join up across the network. So this is one of the things we wanted to do, wasn't it, John, is to bring Humber and North Yorkshire together. So we've done that tonight. Get yourselves home safe, and hopefully we'll see you at a future event that we will run at some time.